Are you are you both coming up? Oh, moral support. Hey everybody, we're going to get started in just a minute, but I'm going to turn the mic over to Forrest from CareXM and Moral Support to share a few words. They're our gold sponsor, and of course we couldn't put on conferences without the support of our exhibitors and sponsors. So please welcome the CareXM team.
Thank you, Barb. So this is Laurie Nelson. Laurie works out of Utah, which is where we're headquartered. And I'm Forrest Perkins. I work out of Nashville. And Barb, I thought for sure I'd win the contest about the furthest traveled. But Miss Morissette got me. Yes, but we're thankful to be here and thankful for this opportunity. And CareXM really is a mixture of technology and services. And what we're really trying to do is partner with people like yourselves to drive down the cost of triage and also improve that experience for the caregiver, for the patient, and for the nursing staff. And how it kind of got started was our founder was actually a cancer patient in his home receiving chemotherapy. And his home health nurse was changing out his port, and her phone would ring, and he would see on her face just the angst, right, and the anxiety. Do I take this call, or do I stay with this patient? And then when she took the call, it obviously left him feeling a bit vulnerable. So thankfully, everything was all right with Kevin. And out of that, he started meeting with some hospice nurses and came up with this idea now known as CareXM, which again is a mixture of our CareXM platform, the technology, backed by on-demand triage nurse team. So we work with organizations to help take calls that you can't take or that you don't want to take, and also make more efficient in the process of taking those calls. So again, thankful to be here. Barb, thanks for the opportunity, and Meg. And if anybody would like to come by, we're out here at the booth and would love to talk to you. Anything else that I missed?
No, just it's fun to see some friendly faces, some partners who are already out there, and we just love what you're doing in the industry, all of you. I was joking with Stacy, I'm like, telling your stories, I don't miss going into patients' homes sometimes when you have to move the gun and the crack pipe to do the quad wound care. That's my story of the last time. I'm like, yeah, I might need to find something else to do with my clinical license. But I don't even want to take away from the fact what a special job that we do as home health and hospice members. You know, I've been doing it for about 20 years now, and it never gets old. But when you've had a family member who needs services, you know, your attitude changes about it as well. So we do such a great service, even among the unsafe conditions we may be exposed to. So thank you all for what you do and who you are. We really appreciate it.
Okay, thank you. Okay, Cheryl, would you like to come up and share about the app you showed? She forgot to share this during the presentation. I said, well, you have to come up and share about it, because it's about safety. So Cheryl Metawattage is from Evergreen Health, the other Evergreen, as the Albany Evergreen folks refer to it, the other Evergreen in Kirkland. And how does this app work, Cheryl? And please confirm that you are not a paid endorser of this app.
I am definitely not a paid endorser. I did want to mention, I love the Dr. White calling into your office. That's a phenomenal idea, so thank you so much for sharing. I also wanted to mention there's an app on Android and/or your iPhones. It's called Noonlight, N-O-O-N, Light. It pretty much, and I've accidentally set it off before, so I'm going to be very careful. But if you are in a situation that you may not be able to call somebody, it's $2.99 a month, guys, very inexpensive. You hold this down, your button. It's a panic button. Hold it down, release. They dispatch 911 to your location. It's a great app. I'm exploring it to see if we could get our clinicians, our company phones, to get that app on their phones as well. But it's a great app to consider. Oh. What's that? How does that work in sketchy cell service? I think as long as you've got, I mean, of course, it is conditioned. You have to have, some type of satellite service, but it does pinpoint your location to the T, and it dispatches the police right away. It's called Noonlight.
Noon, like 12 noon.
Yes.
Light.
Light.
Does it alarm if you push that button at all?
It vibrates. Yeah, if you have it in your pocket, you'll know that. And they may try to reach out to you, but of course, in those situations where you're just pressing the button and releasing, they know it's a panic situation. So, anyway.
Okay,
All right.
thank you. Thank you. And I wanted to make sure that the thank you card for Judy Lund Person is still making its way around. She texted me at 12:30. She has arrived at the Portland airport and is on her way here. She'll be joining us at some point this afternoon. So who has the card? Oh, very good, very good. Thank you. And just make sure that goes around if you want to sign it, and we'll give it to her tomorrow. By the way, I forgot to mention that I also have some extra rocks. If anybody wants to give Judy a rock and you don't want to go out shopping for one this evening or out in the parking lot looking for one, see me at the table. Okay. After lunch, we're doing our Fit in 30 presentation. So we're going to be fit and quick and keep everybody awake. And I'm putting that pressure on myself because we're going to start with urban legends and old spouse tales. I didn't want to be, sexist and say wives' tales, so old spouse tales. So these are things in my almost 8 years in my current role, things that I used to believe were true, frankly, when I was director of a program. And these are still things I hear a lot. And so I thought, well, it'd be kind of fun to go through them. And there's no poll everywhere. I may ask you later to, hold up a green or red if you cover something during atypical treatments, but we're going to just start with some urban legends. So let's see. So learning objectives, you can see those online. Hopefully you'll walk away with something. And I do know that tails and tails are homonyms and are spelled differently. And the photos used are from my personal collection. Well, there's one at the end, but mostly Creative Commons and have not been altered. So let's talk about how you create your program policy. And it's a long and winding road, especially if your programs have been in existence for 40-some years, like some programs in this room. So you have, the policy is born. Somebody gives birth to the policy. Could have been even before there was Medicare hospice. And then you have a Joint Commission surveyor, as it used to be called when I was a surveyor, JCO. And the JCO surveyor tells you something, and so you change your policy to read that way. And then your executive director changes and comes in and has new ideas. That never happens, does it, Cheryl Metawadage? And then CMS issues a wage index rule, and there's a new rule. And so you either have to amend your policy or create a new one. And then your medical director changes. Well, a certain amount of stuff goes out the door when your medical director goes, including his or her preferences for how they want things to be, right? So you get a new medical director, and if you're lucky, they haven't been at another hospice, because you can then, train them the way you want them to be. Sorry, doctors. Then you have a CHAP survey. Heck with Joint Commission, who now you're getting CHAP. And that surveyor has a different idea for how things should be and tells you to change you need to change your policy. And then the state licensure rule changes. Now, this happened in Washington State in 2018. It happened in Oregon in January of this year, but the tweaks in Oregon were so minor, most people in Oregon aren't even aware. In Washington, they were a little more substantive. Anyway, but you have to change your policy. Somehow you come down this long and winding road, and you've got your current policy in its current iteration. So this is just a long list of sources of, where policy information comes from. I know these slides are really busy. I apologize in advance. It's just some ideas. If you have downloaded the slides, or you can read this, which I'm not really sure I can. So did I leave anything out for a source of policy? I included on here what your durable medical equipment and pharmacy contracts either allow or require, because that can impact your policy, right? Anybody have anything that's not on the list to toss out? Okay, I guess. Anyway, so I heard this when I was a brand new nurse. And as you heard me say when Marisette was here, I was a brand new nurse in 1981, so that was a long time ago. 50% of what you know is based on the policies of where you're working at the time. And I was highly offended by that in 1981. And now I think, I'm not sure if it's 50%. It might be 70% of what you know is based on the policies of where you're at. So how many of you have experienced working with a new hospice staff person who did work somewhere else, and they think your hospice must be doing it wrong because over here they did it this way? I mean, it happens all the time because there is so much gray area in hospice that each hospice gets to decide how you do it. And a lot of it comes down to your medical director, your executive director, the history, whether you're based out of a hospital, whether you're an independent, you know, it's just, there are just so many variables. And do you think the use of electronic medical records has helped this issue or exacerbated? This is kind of a poll everywhere. Can we agree that it's exacerbated it? Because you used something else over here and now you're on, dare I say the four-letter word, Epic. I've used Epic, I know what I'm talking about here. So anyway, so does anybody else have any examples of, you know, when you hired a new staff person and they thought this program did it wrong? I mean, your program did it wrong because their old program did it this way. Anybody want to go to the mic and share some examples, or shout them out and I'll repeat them? Maybe some of our virtual attendees want to blow up the chat as, yeah, Dr. Younger.
I would just say that the reverse is also true. I mean, when I was in the business of hiring people, I would often say on their first day, I want you to come back in a month, not 2 months, because by 2 months or 3 months, you'll think the way we do things is the right way. But I want you to come back in a month and tell me what we're doing that's crazy.
Yeah, because actually their other hospice could have had a really good idea that your hospice hasn't thought about yet. Yeah, that's a great point, Dr. Younger, I appreciate that. Anybody else? Okay, so I put this buckets analogy in because these are some like major buckets. So you've got federal regulations, and that could be OSHA, you know, it could be CDC guidelines, and then state regulations, and then the preferences of your interdisciplinary group, which includes your hospice medical director or other hospice physicians. And then there's lots of other influencers. But do they all weigh the same? Do all these buckets weigh the same? Of course not. And every April and then every end of July for the October 1st final wage index rule, the federal rules carry a lot of weight, and so those impact your policies more. So here now we're going to get into some of the urban legends, and that's what Judy Lundperson calls them too. Only physicians can give a hospice referral. But some people believe this. So you have to make sure that all of your staff understand that anybody can give a hospice referral. I could refer myself for hospice, or my neighbor could refer me for hospice, or the postman woman could refer me for hospice. I mean, anybody who thinks that somebody has a terminal illness. Now, ideally, you'd like to check it out with the person themselves and with their, if they have a community attending physician. It depends if you consider a referral as an oral CTI, and we'll get to that in a moment. So only physicians can certify a patient, but anybody can refer the patient. And if you do have a policy that only a physician can give you a referral, then you would be expected to follow your policy when a surveyor comes to visit. But overall, this is not true. So if you have a policy that says only physicians can give us a referral, you just might explore why that is. And do you know, is there some foundation? And there could be, but you know, technically, this is not a Medicare or a state regulation in either state. So then, this is one I've encountered a lot too. A referral from a physician's office is an order. Maybe, that's right, maybe. Because it could come with the old-fashioned evaluate and treat kind of order, or you could consider it an oral CTI. And if you consider oral CTIs as verbal orders, then it would be an order. But it sort of goes back to how do you process referrals and how do you take oral CTIs? And we're going to talk about that more in the verbal order session, so I need to stay on topic here. But the hospice conditions of participation and the conditions of payment do not require that a referral equals an order. But the referral, if it's coming from the attending physician's office and does contain some treatment orders, then it might be an order. So it's sort of like, maybe is the right answer. I think Christina got that back there. Okay, here's probably the most common one in America. The CMS COPs require an RN to visit the patient every 14 days, every 15 days. And this is not an actual regulation by Medicare. But I've talked to people who do consulting nationally, and they say everybody thinks this. Everybody in the country thinks this. So what the CMS COPs do say is that you have to complete an updated comprehensive assessment at least every 15 days. And how most people do that is by doing a visit. And so then you have a program policy that says we have an RN visit every 14 days. And maybe they could also do that hospice aid supervisory visit while they're at it, by the way. So you're killing two birds with one stone, right? But there is actually nothing in the CMS regulations that require or specify a visit frequency. So it's just how do you operationalize it at your program? And technically, the updated comprehensive assessment is supposed to be done or more often as appropriate, and we tend to fall back on the every 14 or 15 days. And meanwhile, if you look back, maybe something major happened in between, but we didn't really update the whole comprehensive assessment. So, or you maybe had a nursing visit that provided some assessment information, and you're going to say, that's how we updated the assessment. But anyway, there is nothing in the COPs that requires any sort of visit frequency. Anybody have any questions or comments? And it's fine to have a policy that says you will have an RN visit at least every 14 days. I mean, that's totally fine. In fact, Judy Lund-Person told a story once, maybe even at this conference one year, about how she overheard the owner of a hospice talking about they only had their nurses go out at the most once a month. And sort of regardless of what the patient needed. But, you know, they didn't spend a lot of money on labor because they only were doing monthly visits, because technically there's nothing that requires, and maybe they were doing phone calls in between and updating the comprehensive assessment that way. Anyway. Okay. Sorry, did I hear the word social work in a sentence? Oh, no. Some of my best friends are social workers. For any discipline, there really isn't, other than you have to, now when the waiver's in, you have to evaluate the hospice aid every 14 days. Okay, let me see. Did I cover anything else there? Okay. Here's another one that I hear commonly. A respite stay cannot occur right after a hospital discharge or a hospice general inpatient stay. And there's nothing in the Medicare rules that prohibit an inpatient respite stay taking place right after a hospital stay or a general inpatient stay. But what you have to document, because respite is always about the patient family's caregiver need for respite. So you have to say something like, they were with the patient 24/7, they're exhausted, they're sick, whatever it is. But there's no billing prohibition. You may have a program prohibition because you're trying to hold off any audits from happening. And I don't know how often really audits happen after this, but there is no rule. And when I worked at a program with an inpatient hospice, we would hear that from a lot of our hospice nurses. Oh, well, they can't come to the hospice house right after being in the hospital. And I'm like, why not? I mean, for respite. And often what we would find out is actually the reason the family needed respite was because there's some symptom that's out of control, but that's whether they were in the hospital or not, right before. But there's no rule. Yes, please. However, I love sentences that begin with however.
We have to do the admission in the service location where they're
Right.
going to be having their service.
Right.
So you're saying that the service location is going to be their respite.
Could be, whether it's at a nursing home or a hospice house. And I'm not, but with any of this, I'm not saying you have to go change your policy. I'm just sharing that a lot of things that we think are Medicare rules are not really Medicare rules. There are program policies that were put in place for some reason. So, no, I don't mean to shoot that down. So, yeah, the assessment would take place either in the hospice house or more likely the SNF.
Right.
Yeah. Right, yes. It can't be because of lack of caregiving. It's because the caregiver who does exist is exhausted or sick. And why do they often need respite? Because they don't have a caregiver, frankly, and they don't have a symptom that's out of control that qualifies them for GIP. Exactly. It's a lack of adequate long-term caregiving in our country. Yes. Yeah. Great comments. Okay, let's see. It even says this in the rules, and I've provided these references in the slides that I know are way too busy and contain too much information. It's mostly so you could take them away. Okay. Let me see. All right, here's a question I get too. And again, this is way too much information. I'm just trying to provide the reference that you take home later. The QIO can prevent you from discharging a patient who is no longer terminally ill. That's absolutely false. But a lot of hospices think, okay, I guess we have to keep them on, but we can't bill for it, but we got to keep them on. No, if you don't have orders to see that patient and your hospice medical director will not certify that patient as meeting eligibility criteria, then you don't have orders, and these rules do not supersede your lack of practitioner's orders. But it's just surprising how many people are intimidated by that whole QIO process. And you can also refer that beneficiary to other hospice programs whose hospice medical director may have a different opinion about their eligibility, and that's fine. This is not, a hard and fast science, but you don't have to keep providing care for that patient and not bill for it, frankly. Yeah, please. Uh-oh. This is going to be good if it's coming from Stephanie.
It's not that great, but it just, it's something else that if you do have the ability for that patient to self-pay for those hospice services, then that could be an additional way that they could still have the hospice benefit,
Right.
but they're going to be paying out of pocket for that.
Right.
And that's just another method of how we could still potentially provide care. As Cheryl was saying, nobody wants to do that, which is true.
No,
but
wait,
that
I
is
was
a
gonna say,
potential
you're-
possibility.
You're from Snohomish County where there are Microsoft and Amazon millionaires who could pay out of pocket for hospice, right? Who has that many patients who could pay out of pocket for the hospice benefit? But no, technically you're right. And you would issue an ABN and you continue to provide the service. If your medical director would, or the attending would provide orders, you wouldn't be billing Medicare, but you would, yeah, that's a great point. I appreciate that. That's right. Yeah. I don't know, what we call that hospice light, hospice private pay? We don't have to follow some of those regulations? Yeah. I just don't know of very many patients who, other than Snohomish or King counties. They're all in King County, not Snohomish County. Okay, all right, let me see. Any questions about this issue? So it's kind of in the fine print. All right, no, I was afraid Chris was going to get up.
So what about, no. It's
Wait,
just a
say
comment.
however.
It's just a comment that we get put in these uncomfortable situations
Yeah,
because this is a hard phone call or a message
yes.
to deliver to a family.
Yes.
When the QIO has ruled in their favor and they get a letter saying,
Right.
oh, you're correct. You win your appeal.
But
And
we're
then
not
the
gonna
hospice
serve
comes
you.
out and says, so?
Yes.
So it's just that's a very
You're
hard
right.
spot to be in.
And you know, it says you're supposed to make your hospice medical director aware of the QIO's decision, and they can rethink their position. Who's a hospice medical director or physician in here? Haven't you agonized over these decisions already? You're not going to rethink your position. You've already probably kept them on for a certain period too long. Let's be honest. Okay, thank you. All right. Okay, this was an interesting one I just sent around, and so many people responded. I appreciate it. An order is required to change a patient's level of hospice care. And I think there were 2 hospices out of 40-some in both states who responded, who said no, they don't require an order. And the answer is, it isn't a requirement. However, NHPCO's survey process guide considers it a best practice. Some of your EMRs will require it for changes to continuous home care because it helps with the timing and the billing. But it's actually not a requirement. However, it could be your program policy. And I'm not arguing against it or for it. It's whatever works for your, oh, Christina. However, you have to come to the mic, do you mind? Sorry, for our virtual attendees.
You don't want me yelling?
Well, no, you can yell, but just yell into the mic.
So technically, we would have to change the plan of care, which
Right.
then is an order. I mean, it's not written into regulations, but it technically
Right,
is,
right. It's sort of whatever your process
Yeah.
is, but technically, it's not required by the Medicare hospice
Right, an
regulations.
order,
But
the plan of care has to be
NHPCO
updated.
considers it best practice. And if you're updating the plan of care, you're right, because this is, and you should update that comprehensive assessment too, by the way. Right?
Yeah, so are you in agreement that the plan of care needs to be updated?
Yes,
Okay.
yes, for a change in the level of care, absolutely.
Perfect.
Yeah. Okay, let's see. I think we're good on that one. Only RNs can take after-hours call. Technically, there has to be an RN available to them. Now, it sort of depends on, pragmatically, do you do a lot of after-hours admissions? Because if you do, you know, an RN has to do the initial patient assessment. That has to be done within 48 hours of signing the election form. But if you don't do very many after-hours admissions, or, you know, I don't know, you have a plan for that, nursing services are required 24/7, 364. 364. I'm like doing the opposite of leap year. 365. That's on the other planet I serve. So there are issues in each state about what LPNs can do. LPNs are not supposed to independently update the plan of care or independently assess. They contribute to the assessment. But I remember one hospice program director telling me, we have 3 RNs and 1 LPN, and I'll tell you frankly, our LPN is way more experienced than there are 3 RNs. And she was more experienced in another area we're going to talk about. So it's really a program decision, but if you have an LPN who has experience and sort of knows how to triage, and you have an RN who's technically on call for that LPN, should something come up, because an LPN is supposed to work under supervision of an RN, then you would be okay. And here's another one, and that same program director told me, and furthermore, our LPN is way more experienced at administering IV medications than any of our RNs. She used to work in an IV outpatient clinic, and she has all kinds of experience. So a lot of people think this is some sort of state regulation, but it's not in either Oregon or Washington. Now, it may be in other states, but it's not in Oregon or Washington. So it depends on what your program policy is. And in hospice, we don't tend to give a lot of IV medications anyway, so it might be a moot point for your program. But it's just, again, this is one of those urban legends that people sort of propagate. And I also get this question on occasion, and how often must an RN do an LPN supervisory visit? There's no regulation in the state, either state or Medicare about this. But if you have a program policy, then you would be expected to follow your program policy. I know I'm sort of like a repeating drone on that, but it is what you say it is. So there used to be, Molly, do you remember back in 1986? There was a state, I think it was a state of Oregon home health rule that an RN had to do an LPN supervisory visit every 30 days. But that went away. Yeah, so that existed in Oregon. I don't know if there used to be an old rule in Washington, but that was a rule in Oregon decades ago, but it hasn't been there for a long time. So, does anybody else have another example of a hospice urban legend? I have one I'll pull out if nobody has one, because I know we have to start our other presentation. Okay, a lot of people think you have to have an IDT meeting every 14 or 15 days. You don't. You have to update, you have to collaborate, communicate, and update the patient's plan of care every 14 or 15 days. It doesn't have to be in a meeting, but that's how most hospices operationalize that requirement. But there is no regulation that you have to meet every 14 or 15 days for 2 or 3 or 5 hours or however long it takes. Okay, these are just references for you to take a look at for policy creation. I think many of you know about, Appendix M and Chapter 9 and Chapter 11. The Chapter 30 is the Medicare manual that talks about using ABNs and NOMNCs and those forms, so those are good sources. So my suggestions: review your policies on an annual basis, involve clinical staff in that policy review, see if, and of course, if there's been a new regulation, you'll want to update your policies. Ask yourselves if you still need that policy, and if nobody can remember why you have that policy a certain way, and if it's different from what the state or Medicare requires, ask yourselves if you need it. Blah, blah, blah. Okay. Especially if your policy is more stringent than what Medicare or the state requires. And for those of you lucky enough to serve both states, and some of you might even serve Idaho, Oregon, and Washington, if you're more strict with your policy than what any of those states require or what Medicare requires, ask yourself why that is. What purpose does that serve? And there could be a purpose. It works better for your workflow, or your EMR. Okay, sharing time. I think we're out of time for this. And so look at the time saved by the bell. And we have to go to our next Fit in 30 presentation because we have other speakers besides me, although I am going to start. And I'll be happy to take questions at the break, if worst case. So Clint, are we ready we are making the switch. We're going to talk about atypical treatments because so many of us wonder, do other hospices cover this? Are we being asked to do something that other hospices are also being asked to do? Are we required to cover this? So this is going to be a panel presentation, not just me. I'm just going to do some of the intro slides. Tracy and Dr. D, do you want to come up here? I know you're walking with a cane. Would you be more comfortable there if we brought you a mic? What's your druthers? There is, no, there is a step over here on the side. Tracy's coming up. So Tracy Villarreal and Bill Dronkowski, Dr. Dronkowski, are from Care Partners in the Portland area. And we have Dr. John Younger. Would you please come up from Klein Gallen Hospice in Seattle? And then virtually presenting will be Dr. David Brunel from Providence Hospice of Seattle. So I'm going to start with some atypical treatments. And I'm happy to lend a hand or okay, maybe move my chair out of the way. And Clint and Jeff, are these mics live when they want to share? Okay, so I'm going to do just some quick introductory slides, and I'm going to go through them quickly because I want to get to real-life examples of decision-making and processes for deciding what to cover. So I'll just skip over the learning objectives. We don't have any conflicts of interest. I had to put this in because I created the learning objective that included it. So what is stewardship, and is it a bad thing? It's really taking care of your hospice's resources, right? And does anybody besides me have an example of when the downside of stewardship? Anybody have any examples of, you know, we maybe weren't good stewards and this patient cost us X thousands of dollars and we could have done things differently? So at a previous home health agency where I worked, we actually closed, at home health and hospice, we closed a branch office because frankly, the interdisciplinary group was not really good stewards and covered every medication that any patient wanted, and lost so much money that we were a department of the hospital said, we're closing that branch office. So that was stewardship, I suppose, but it was a hard lesson, an emotional lesson to have to close an office and tell other people they were laid off. So anyway, but it is important and it's valid, and it's the reason why, I mean, we have to stay in business to serve future patients, right? So anyway, so in the original 1983, I think this reference is from 83, I have provided the link on the side, CMS said, it is our general view that the waiver required by the law is a broad one, that hospices are required to provide virtually all the care that is needed by terminally ill patients. And the proposed rule that came out 2 weeks ago says essentially the same thing. I think it wasn't CMS back in 80s, wasn't it? HCFA, Healthcare Finance Administration. Anyway, but now, of course, they're called CMS, but they're saying the same thing. They want hospices to cover virtually all of the care. Hospices do still get to decide, for example, if you're going to have a formulary, if you're going to consider a treatment palliative versus curative or life-prolonging, because you're being asked to cover more than hospices ever were before. And you can decide not only to have a formulary, but what your usual progression of medication orders are, and how to manage their psychosocial issues, you know, which referrals you're going to make, how to manage safety concerns. A lot of that is that gray area that's left up to hospice. And how to honor a patient's right to make their own choices, because hospices are called on the carpet if your patient decides to revoke and go have surgery. Somehow that's your fault. But they have, you know, those right to make choices. And I'm going to speed through this. There's no one answer book, of course, which is why if you're wondering about covering something or you're being asked to cover it and you want to know if other hospices are covering it, I am always happy to make a connection for you or to put out a listserv question. But, you know, some of these sources come from your peers or CMS. And here's an example of a journal article, the most common medications billed to the Medicare hospice benefit among hospice beneficiaries in the US. So this is what other hospices are covering, the top 20. And let's see here. And here's on the Medicare Interactive website. This is available to consumers. They explain drug coverage under hospice. And what I want to get to, this is too fine print. It's more information about hospice costs and coverage. Are your staff able, when they go out to admit a patient or talk to them about hospice, are they able to answer the following questions? And these came from NOC last year. I think this came out in last fall or December. Questions to ask when choosing a hospice provider. So what kind of out-of-pocket expenses should be expected for hospice-covered services? So your staff might be asked that. And another one is, are there any services, medications, other treatment, or equipment that the hospice does not provide or pay for as it relates to my condition? So maybe your patients and families aren't asking these questions yet, but they might be, and maybe some of them are. And so our 4 speakers have graciously agreed to share some of the processes for how they made some of these difficult coverage decisions. And I think we are going now to Dr. David Brunel from Hospice of Seattle.
Hey, Barb, can you guys hear me okay?
Yes.
Okay. I've got 8 slides. It's fit in 30. We're down to 20. There's other people on the stage. I'm going to be really lickety-split, you guys, but it's nice to see you in a land where bird song fills the hallways in Vancouver, Washington. I wish I were with you. So, as Barb's already mentioned, what is related? Short answer, just about everything these days. But the way I like to think about it is through a lovely algorithm NHPCO has provided to all of us, everything filters up to the terminal prognosis. So that we have to find a qualifying diagnosis, of course, that we're going to attach that makes it most likely that that patient will succumb in 6 months if the disease follows its natural course. But there's all sorts of contributing diagnoses that also make that 6-month terminal prognosis much more likely. Those are also considered related. And then finally, any symptoms resulting from the qualifying diagnosis, the contributing conditions, or the treatment of any of those diagnoses and conditions, all of that is considered related. So then the question becomes, I've kind of talked about this already, so I'm going to go right through that. What should we cover? Pretty much everything. Everything related to those diagnoses, conditions, and symptoms. What I have found is the secret sauce, and I think the others on the panel are going to be able to talk about this too. The more we can legitimately increase length of stay within the confines of the conditions of participation from CMS, it makes forays into these more atypical forms of care support much more manageable from both a financial and a care perspective, and everybody sort of benefits. I'll talk about that in a minute, but I thought it would be worth reviewing very quickly the things we know lead to an increased length of stay. A more timely referral when a patient becomes appropriate for hospice services. The better we can manage the symptoms related to these conditions, the longer the length of stay tends to be. We know the metabolic toll taken on people's lives when they have out-of-control symptoms and we're not good at managing their pain or dyspnea. We call Providence of Seattle a ministry, but your organization or ministry, if you have a trusting profile in the community, your length of stay, data will show, tends to be elongated as well because it's considered a great relationship between you and the community, and then strong community partners. There are 2 people in attendance out there today who are primarily responsible for the information I'm presenting to you, and that is Stacy Jones and Mac Danique. There are directors, clinical directors here at Providence Hospice of Seattle, and they are the ones who implemented these contracts you're going to hear about. I'm just the recipient of their really great management and leadership. And then Dr. Bruce Smith, who was my predecessor here, also was instrumental in getting these contracts in place. So dialysis is one of the things that we have chosen to provide to a select number of patients at Providence Hospice of Seattle. And the way we've done that is we've partnered with the Northwest Kidney Center, where they have 16 different sites throughout King and parts of Pierce County. Dr. Dan Lamb and his palliative team, comprised mostly of a nurse at the bedside and also a social worker, are our liaisons, and they can feed patients our way that they think really have a 6-month terminal prognosis but just don't want to give up the dialysis at this point. And they can also have those goals of care conversation in an ongoing fashion as the patient continues to receive dialysis under the hospice benefit. So we include that for those patients at an all-inclusive rate. And initially, when the program was launched, we thought about a 10-session limit and very quickly realized that there wasn't any really good reason to try and limit people to 10 sessions. Some folks were already dropping out a little bit earlier than that. Some folks never made it to 10 sessions, but the truth was the longer the length of stay, the easier it was for us to actually afford this, and it was in everybody's best interest. So because people love data, right now the contracted rate, or at least the last time we checked for hemodialysis, we pay $300 to the Northwest Kidney Center per session. So that could be up to 3 sessions a week, depending on these patients. And you'll see the revenue codes that we use and also the CPT that we can attach to that have allowed for this to work. Everything that they want to do associated with that, if they want to do pre and post hematocrit, if they want to track down some electrolyte levels like calcium or potassium, that's all considered part of this per fee that we're doing. They can do whatever they like at Northwest Kidney Center. They're going to get $300 from us per session. And then, of course, we provide the other things that are part of the hospice benefit, including DME and the usual visits in the home. Peritoneal dialysis we cover at $130, and the codes are slightly different. And then Trilogy events. Back in 2017, Providence Hospice of Seattle decided that they wanted to make a go of this and see how they could do it. And what we've come up with so far, and again, the whole point here is just thinking creatively, making sure that when we're afraid, when we're concerned, when we're reluctant for all sorts of good reasons, we don't allow that to trip us up right away. Take that first couple of steps, into the future and see how it lands. Currently, our protocol is that we take only patients with ALS as a primary diagnosis, and they already have to be on the Trilogy vent so that we know it functions well for them and they are used to the equipment. Having a respiratory therapist in partnership is really key and crucial to this. Obviously, this is a really complicated piece of medical equipment, and as they decline clinically, there's going to have to be adjustments to what takes place. And we have a general rule of thumb that the settings can go down with time in support, but we're not going to keep escalating care because under the hospice philosophy, we're not looking to prolong life, just to provide more comfort. There you have it.
Thank you, Dr. Burnell. Appreciate. Are you going to stay on in case we have time for questions?
Absolutely, but I'm also going to mute myself.
Okay, thank you. Okay, we are going to go to Care Partners' description of their new process. And Tracy, I don't know if you want me to advance your slides, if you guys want to stay there. You can't
Yeah, that'd
see
be great.
them.
We have a laptop we're sharing here.
Yeah, we still see David on the screen, so we need to go back to the slideshow. The one where I had the slide intentionally. Oh, there it is. Shut up, Barb. Just look. Okay, so this is you're going to talk about how you revamped your protocol for basically deciding these complex care processes. So
I would like to say before Tracy comes in is I was, I think, part of the push to have this done because Care Partners had a reputation that they had purposely built before I got there, that they were very open-minded about covering things other hospices wouldn't cover, that they were patient-oriented. And that is all well and good, but I think that we found more recently that you can't stay in business if you give away, more than what you are billing. And so
stewardship.
this was our way of taking a look at the process of how we decided, because of that reputation we had, we were getting a lot of referrals for patients that no other hospices would take.
Right,
Patients
right.
that were getting TPN, patients that were getting IV fluids, you know, patients that needed a trilogy ventilator. And so we decided we needed to start screening these people when they came to hospice.
Sure. So I don't know if you want to cover this slide or have me move on, Tracy. It's the process
Sorry.
for review of complex patient needs.
I'm just looking at his
Oh,
screen,
sorry.
sorry. I can't. It's too
It's
far
really,
away. I
it's
You know,
really, you're,
for practical purposes, that's just what our program, you know,
Sure.
is. I don't think it necessarily
how to
gives you all
move
the
here.
rationale.
yeah, and I think people, I've gone to the next one, complex needs and interventions. I think people understand what those are. So really, we'd like to hear, and then I have a very busy slide here that lists all the possible complex.
Well, that's just it. It doesn't list all
Oh.
of them. The key is on the next slide where it says, and/or any other complex procedure or admission that would require complicated care that the nurses wouldn't be necessarily familiar with, that would
that's
require new
before.
equipment.
Good.
Here, there, that's the
Yeah.
one
Right.
you just passed.
The one before that, Barb, sorry.
Okay, so I need to go back. There we go. The complex needs interventions? Or-
Yes.
Okay,
Patients with complex needs and interventions which are subject of this process include those who wish to continue or commence using or whom care partners, providers, or staff contemplated commencing, include complex, unusual treatments or interventions that may be viewed as beyond the traditional hospice coverage, and they might include equipment, medications, or procedures, or interventions. The key here was or complex procedures, medications, or procedures that the nursing staff would not necessarily
Right,
be
right,
familiar with.
right. Okay, good. And so tell us how you decide to triage this. Because you have revamped, so you have a process, and we have a couple, I think, 3 slides about it, but maybe you could just sort of
Yeah.
tell
I'll
us how
summarize
you're doing
I
that,
think-
please.
I think what's happening for our organization is we wanted to kind of get a plan together, and it sounded really familiar to me when Providence was up here earlier talking about their complex case consultation, and that we include psychosocial needs and safety as part of that discussion, but we really wanted to get all of the different disciplines, if we could, in the room that would be impacted by whatever that need was, whether it's a complex piece of equipment that the nurses may need training on, whether it's a psychosocial issue that there's a complex family dynamic or a safety issue. We felt like what was happening is we were sort of rushing out the door to go, see the patient and potentially do an admission. And then on the back end, it was, why didn't we know about X? Or why didn't we know about Y? Or what are we now going to do about this? We've already admitted the patient. And although we may have had information that was in the chart or that we had gotten as part of the referral, it felt like sometimes that there were areas that one person might not put a lot of emphasis on until sort of after the fact, and then they were sort of being included after that. So at this point, we've spelled this process out to our referrals and admissions team saying, these are the things that we're kind of wanting you to be screening for, things that might jump out at us as something we would want to talk about. And if they're finding things like that during their referral process, then they are escalating that to the supervisor on call, who then is getting one of those quick, 15-minute huddles to discuss, what else do we need to know? Are we missing something? Do we need to be talking with other people and including them in our process? Do we need to go out and lay eyes on this person without an admission to gather more information and bring it back? And getting everybody in the room together to do that quick huddle, I think, has alleviated a lot of the angst that happens after the fact if you're
already coming in
So
with
you're
a
trying to be
plan.
more deliberate in your process
Yeah.
and slowing it down, and it may result in delays in admitting someone, right? While you figure out if you're going to
And-
cover
And
it.
I
Yes.
think that's one of the keys, is the
Yeah.
problem is you've admitted someone, and they say to you when the nurse comes out, but I was told you were gonna carry on my
Right,
TPN.
right.
And it's much harder to back out of it at
Right.
that point without looking bad than it is to start the conversation by either we don't cover it, or we cover it under these limited circumstances and with this type of supervision and this kind of monitoring to continue to be sure that this meets our quality of life
Yes,
needs.
yes.
Not just prolonging life.
And if it makes you slow down and delay admitting, and the patient or family are impatient, they can, I guess, suppose, try
Yes.
to find another provider, but maybe they'll appreciate that you're putting some care and thought into this.
Right,
Yeah.
and I feel like we're starting out then on the right foot with everyone
right.
because we all have the same
You're
level of
gathering
understanding,
information, yeah.
and we don't delay it unnecessarily, right?
Right,
If there are
right.
additional questions or information we need, we can act very quickly on that once we have that additional information. But I think, keeping our referral partners in the loop about what we're doing and why and what our concerns are is very helpful. And the whole purpose of the meeting is to try and remove those barriers ahead of time so that you can still get to that, yes, we want to help you answer.
Yeah.
But we don't want to say yes and then say, well, we really meant no.
Okay,
So,
Well, and we also want to say, like, it's much easier for me as a medical director to say, okay, we're going to authorize this family because of these quality of life issues and needs to get IV fluids twice a week or 3 times a week for 4 weeks, and then I'm going to sit down
Yeah.
with them and rediscuss whether we're accomplishing what we want to do or not.
Yeah, okay. Well, in the interest of time, we should move to Dr. Younger, and I think you have some slides, so the magical people in the back, we'll put those up, and it's just the green advance button there.
Okay. So, and while the slides are coming up, let me just say, first of all, it's a great pleasure to be here, and the information that I think you all just received from the 2 presentations really constitutes great information and background. In my simple way of thinking about this, I tend. Yes. Can I move this? Okay. Is that better? Yes. In my simple way of thinking about this, I tend to think that, if it's best practice, if it's palliative, if it's consistent with the patient's goals of care, and if the patient's prognosis makes it reasonable, we should do it, almost irrespective of cost. And that works, except when it doesn't. And I think that a great example of when it doesn't work is the example of dialysis. I think having a contract for dialysis is a great idea. I wish we had one, but we don't. And so we don't take patients whose terminal illness is renal failure on dialysis. Hopefully someday we will be able to do that, but today we can't. So again, consistency is overrated in my opinion, and there's a case where we don't take those patients. So let me give you a case that I think is not straightforward at all. Decision could have gone either way. So the patient is a 68-year-old man with metastatic prostate cancer. That's his terminal diagnosis. And he has the symptoms that you would expect with terminal prostate cancer. He's got a lot of pain, he's weak, he's fatigued, he's losing weight. He's also depressed and has a huge amount of existential angst related to his terminal diagnosis. Before he came to us, he had developed a relationship with the AIM Center, and you can see what that is there. But basically, the AIM Center is an organization that has done a lot of work with ketamine as well as more recently now with psilocybin. And he had talked with them about receiving ketamine, but then he came onto hospice, and the thinking was, both by the Ames folks and by us and by him, that now we would get better control of his pain, and with better pain and symptom management and counseling and spiritual as well as psychological counseling, he'd be okay. But he wasn't. He became, in fact, even more despondent in terms of his approaching death and his existential angst. And he developed, again, a very strong desire to do something about that, and in particular to receive ketamine. So, here's sort of the decision tree, if you will. First of all, is ketamine broadly accepted as a treatment, particularly as a hospice treatment for symptom management? And I would say the answer is no. Is there literature to suggest that ketamine might be a really good treatment for some of the common things that we see as hospice and palliative care providers? Yes. Is there literature to suggest that ketamine treatment is safe? Yes. Ketamine has a long history of use at very high doses, and the kinds of doses we're talking about either for dissociative kind of care or even sometimes lower doses appears to be extremely safe. And did we have a way to administer ketamine that we felt would be, in fact, safe with the appropriate oversight, et cetera, particularly because no one in our hospice had experience providing ketamine in this setting. Some of us had experience providing ketamine in a hospital setting for severe pain, but not in this kind of a setting. But the Ames Center had a lot of experience with that. Other questions. Would ketamine theoretically be appropriate in a palliative care setting? Yes, we felt that his symptoms and the purpose of the ketamine were clearly palliative in nature. Is the price of ketamine prohibitive? Depends on your definition of prohibitive. Is the patient aware of the risks and benefits, and does the patient want to proceed? Long discussions with him about those risks and potential benefits, and he did want to proceed. And so we decided to say yes. Now, I have to admit, and I almost hesitated putting this slide on, there is another reason why we decided to say yes, and that was curiosity. We had read, the physicians on the team had all read quite a bit about the potential use of ketamine in the palliative care setting. And I would say potential because there's a lot of literature about what ketamine might do in the palliative care setting. There's very little about what it does in the palliative care setting. There's very little experience with it. And we thought that this was a great opportunity for someone who had a good indication for ketamine treatment, who wanted ketamine treatment. We had an organization with expertise with ketamine treatment. We decided to provide it. So what happened? Now, to a certain extent, what happened is irrelevant to the decision to approve it. This is an N of 1, but still I think it's interesting to know what happened. So he received 2 IM injections of ketamine about 2 months apart. With both of those treatments, he did have dissociative experiences. And with both of those treatments, he felt after the experience was over that it was disappointing. He had expected more. He had expected a much more profound experience from the ketamine. But the story's not over. In fact, over the course of the next several days and weeks, he still felt that the experience was disappointing, but he also expressed less anxiety, less pain, less angst. He used far less breakthrough medications, still was saying, oh, but that experience wasn't what I expected. And when we would say, but did this have anything to do with your ketamine? His response was, maybe, I don't know. But he felt a lot better. It was very interesting. And in fact, he died in a much, much more peaceful state than he or we had anticipated. So again, I use this as an example where I think the decision-making is not so straightforward. Again, I think the answer could have been yes or no, and I would have felt comfortable coming here and presenting this if we had said no. But I think it is the kind of thing that we deal with and the kind of uncertainty that we sometimes deal with when trying to determine whether we're going to cover something or not.
So, Dr. Younger, let me ask you this. Are we going to laugh at ourselves in 10 years when every hospice has ketamine on their formulary and think, remember when we didn't cover it? Remember when we had such angst?
Yes.
So I know we're a couple minutes over time, but I do want to allow time for questions if anybody has any for our panel. And I promise we will be making up this time in my session, not yours, Kathy, necessarily. Please.
Hi, I had a question about the ketamine. If the depression or mental health condition that the ketamine was treating was prior to a terminal diagnosis and determined as not related, would that be covered outside the hospice benefit?
Medicare Part D, I guess, or B? Not sure.
Yeah.
Would it be covered if unrelated?
Would it be covered and potentially covered under in Medicare Part D in this sort of, now this fellow was covered under Medicaid and Medicare actually for his hospice. So it's possible. I think that gets to that more difficult issue of whether depression that precedes a terminal illness and then a person comes onto hospice, and is the depression, how do you tease out what's depression related to that longstanding depression and what's depression that's maybe made worse by the terminal illness. In addition, though, he clearly had very significant existential angst about his impending death, and that made it clear in this circumstance that it was related to his terminal illness.
Thank you. Great question. And yeah, please, Stephanie.
I love this conversation, and so thank you all for all of your perspectives. Something that I constantly think about relatedness as well, and so one that kind of gets into, for me, really gray zone is falls. So if somebody were to fall and have a traumatic injury, right? So on one hand, you could say that this patient is experiencing weakness, and the reason that why they fell, maybe it was a caregiver that dropped them or something like that. But that isn't necessarily related. That's not part of their disease trajectory that somebody dropped them, right? But you could argue, though, that because their bedbound status or, something like that. So what is your thoughts on falls and relatedness and covering any sequela as a result of a traumatic fall?
So basically your question, Stephanie, is every fall in a hospice patient automatically related? And how do you justify saying it's not related? What is your sort of arcane process? This should go to our process question, our group.
I think there's a lot in this question. And a lot of it philosophically, people are going to disagree with me. I think what we do is we say, yes, you have to assume that the fall may be related to this person being frail and to the disease that caused him to be on hospice. So we have to cover the issue related to the fall. Now, on the other hand, he broke his hip. Does hospice have a responsibility to pay for a hip internal fixation Probably not, at least in my opinion. So I think what you have to do is pay for or agree to evaluate the consequences of the fall. But if they want more aggressive therapy than what you think is reasonable under your hospice benefit, then they have to go off hospice to get that. That's the way we approach it. Now, interestingly, I've got a case right now that's a little bit similar. I've got a guy who's got complex heart disease, and he's been on hospice for 2 years and done very, very well with us adjusting his medications. But now all of a sudden he's become seriously bradycardic. And he's having episodes of near syncope, and the other day he had an episode of syncope while he was out working in his shop in his garage and fell. So this was a fall definitely related to his heart disease. But is that pacemaker a hospice procedure? I don't think so. So this is the second time in my hospice career where I've said to the patient, I would advise you to consider revoking hospice. I will help you find a cardiologist that will put a pacemaker in for you, and then you can come back on hospice a few days later once the cardiologist feels that the pacemaker has been placed and you're stable. I've got a lot of discussion going on even within our own hospice over this. But I also, before I was a hospice director, had a patient just like this in the hospital. He was scheduled to go on hospice on the discharge from the hospital. I did not recommend he got a pacemaker. He fell and broke his hip the next day and spent the last month of his life in a nursing home.
So it gets into that issue of, do you consider it life prolonging? Most people would consider a pacemaker life prolonging. And I don't feel like hospice should be forced to cover that.
It
so
isn't,
anyway.
but it's a quality of life issue.
Yes.
I'm going to get this guy back on his feet
Yeah.
where he can go
Right.
putz in his garage and
Right.
shop.
Well, we are over time, so how about a round of applause for, this could have been a day-long session, right, by itself. So thank you for your succinct contributions on this very complex topic. So feel free to get up and stretch or go use the restroom if you need to, but we're gonna roll right into our next Fit in 30 presentation. Kathy Katzenberger has a DNP, so we call her Dr. Katzenberger. And she's going to build upon the presentation she gave last year where she presented some research about making time of death visits. One of the reasons we chose this topic is because I get a lot of questions about time of death visits from our members in both Oregon and Washington. So, Kathy, we will take it away for you, and I'll get that out of the way. You just hit the green button at the top.
Okay. Hi, everybody. Okay, so let's see if we can get through this. Okay. Hopefully I'll be okay. We'll try to get through this. Okay, so the learning objectives will be about participants will be able to identify the state and federal regulations regarding visits at time of death, be able to identify at least 2 factors that influences a family's decision about accepting a time of death visit, identifying which visits are reported for different quality measures, and being able to identify which visits qualify for the SIA payments. So I have no disclosures to put forward. I do want to say, though, Barb Hansen did help me with some of the slides for this presentation. You can recognize her humor in that previous slide. You want to go back? Okay, here we go. No disclosures. So thank you, Barb, for the humor in that. All right, so we're going to get now to the regulatory stuff. Okay, so what does CMS have to say? CMS, the hospice COPs do not have any particular requirements regarding death pronouncements. And this information from CMS about time of death visits is mostly about billing, of course. The modifier, the PM modifier, can be added onto a claim to signify that a visit occurred after the death. PM visits do not, of course, count toward the service intensity add-on payment, and PM visits also do not count toward any claim-based quality measures, which is unfortunate if you think about it in a way. I mean, they're important visits. But what visits do count toward the SIA payment? It has to be the day. The days have to be routine level of care day. The day has to occur during the last 7 days of life, and the beneficiary is discharged as deceased in order to count for the SIA. Of course, the service has to be provided by an RN or social worker for at least 15 minutes and up to 4 hours total for the SIA to count. LPN visits, CNA visits, chaplain visits, unfortunately do not count toward the SIA, which I think there's a lot of debate about that amongst hospice professionals about that, but it does not count for this particular payment. And you cannot provide the service by phone. So unfortunately, the social worker has to visit in person. Or the nurse, you cannot be a phone call. It does not count toward the SIA payment. And if you happen to have, if you're out there, which often sometimes will happen, that the nurse or the social worker will be there when the patient dies, what we recommend that we do at our hospice is that we have the person who's out there to make 2 visits. You stop your visit that the patient has now died, so that is 1 visit, and then you start another visit that is now the after death visit, so that it's clear what time was the patient alive, and that way that time can count. So first we're going to do a little, this is not really a quiz, honestly, but how do you prove that a regulation does not exist? Or how do you prove a negative? I mean, in other words, how can you prove something by not finding a regulation that requires something? This is definitely something that was difficult even for myself when I was trying to do my research study. Trying to explain and prove about time of death visits, that some places, some areas in the United States require them and some don't, and how do you prove, that some areas provide it and are required and some do not? That is not easy to find that information anywhere to be able to use to prove that. Of course, we're both Oregon and Washington are represented here, so it's a tale of 2 states. In Oregon, there is no statute or rule that requires a patient to be pronounced dead, and that is also true in Washington state. However, each county's medical examiner in Oregon could decide that they want the hospice nurse to pronounce a patient's death, and in Washington, the county's medical examiner or coroner could decide that they want the hospice nurse to pronounce a patient's death. Washington State did do one thing that was really good about this. They did an advisory opinion, and you can see the reference here if you want to look at it in more detail. And this was effective in November 12, 2021. I wish they'd had this when I was looking for information back when I did my study. But that Washington State had no legal requirement for pronouncement of death or how a body is to be removed. But there are sections of legislation and regulation that may be relevant to the process of the pronouncement of death and removal of the body in specific practice settings. So within the scope of practice of the appropriately prepared and competent LPN, registered nurse, and ARNP to determine and pronounce death using assessment of their assessment skills to be able to be conclusive about the signs of death. but is not within the scope of the nursing assistant or certified nursing assistant to determine or pronounce death, and it's only within the scope of the ARNP to actually certify death. It is not within the scope of the LPN or the RN to actually certify a death. So now we're going to talk a little bit briefly about coroner versus ME, and you're going to learn more than you ever probably wanted to know about this. There's a lot of information about it. Coroner is actually an elected official. In some areas, it can be also bundled with the sheriff or the consumer community resource. And coroners collect and investigate into cause of death. They contract with physicians to perform the actual medical examination. They may also be physicians, especially in rural areas with minimal resources, but they may not have any medical experience. Whereas a medical examiner is a licensed physician who specializes in forensic pathology. And because a medical examiner's job is based on professional skill, they are an appointed official. They're not elected. Coroner's elected, medical examiner is appointed. So in Oregon, there is a centralized statewide medical examiner system and a chief medical examiner, where in Washington, there's a county-based mixture of coroners and medical examiners, and only 6 counties actually have medical examiners in the state of Washington. And then you can see all the data down here. Yeah. So, yeah, kind of interesting. I learned information I didn't know about that. So, where can the state rules be found? And here's some reference. Oh, wait, I skipped that one, didn't I? Oh, yeah, there's some references you can see where you can find the information regarding those rules and regulations. So when should hospice report a death immediately? In Oregon, deaths requiring investigation is when there's been a homicide or suicide, or it's occurred under suspicious or unknown circumstances. Of course, anytime it's resulted from the unlawful use of controlled substance, if there's been an accident or following an injury, and if it's related to a disease that could constitute a threat to the public health, then you'd want to report that. Okay, and when should hospice report a death immediately in the state of Washington? If the death occurred without medical attendance, the funeral director can actually contact the medical examiner and let them know within 48 hours, that the death has occurred. We do not actually in hospice have to contact the medical examiner every time or the coroner every time a death has occurred. The funeral home does that in a lot of cases. And if the death appears to be the result of unlawful or natural causes, for example, like if a patient fell and that was the cause that caused them to die suddenly, then we would want to report that. If the patient had an injury, a lot of times we'll find that if there was an APS referral or an RCS referral made because there was possible abuse, then we would report that. We would call the medical examiner's office and see if they were okay with releasing the body or not. Usually they want to find out what was the result of that investigation, if it was closed, before they would let us release the body. Looks like there's a question.
Yes, thanks. I don't know how many people in the room do pediatrics as well. Is there a difference for adult and pediatrics in terms of reporting in either of these states or requirements?
Barb doesn't think so.
Okay.
Does anybody else know of anything different than that? There isn't. Okay. Yeah. Oh, yes. Same. Yeah. Okay. All right. So, to-do list. We want to ensure that all staff have access to the contact information for every county's coroner or medical examiner's office. So you want to make sure your staff are well instructed on what to do, including what to do after hours with contact information for that. You want to provide training, of course, to all staff who make home visits regarding when and how to report an unusual or suspicious circumstance related to a patient's death, and maintain liaison with staff at each county coroner and medical examiner's office to ensure that you're following their guidelines, because sometimes their guidelines change. And I don't know, for us, often we'll hear about it from our triage nurses because they've called to report a death, and all of a sudden they'll hear from the coroner or medical examiner, well, we want, you need to do this. So that's how we usually find out that something has changed. I don't know if any of the rest of you have had that experience, but that's how we often find out. So we're going to shift gears just a little bit and talk about two quality measures. You're aware of the hospice care index, and for that is the visits near death, and the numerator of that is the number of decedent beneficiaries receiving a visit by a skilled nurse or social worker staff for the hospice in the last 3 days of the beneficiary's life. And in that case, it's okay for it to be an LPN, RN, or nurse practitioner visits. Those all count in this particular quality measure. The denominator, of course, is the number of decedent beneficiaries served, and the hospice earns a point towards the hospice care index if their score falls above the 10th percentile ranking among hospices nationally. But the other quality measure, which is the visits in the last 3 days of life, which is the quality measure that we're looking at, the hospice visit, in the last days of life. The numerator of this measure is the number of patients' stays in which the patient or caregiver received in-person visits from either a registered nurse or social worker on at least 2 of the final 3 days of the patient's life. So, so there are two separate measures there. Anything you want to say or add about that, Barb?
I get really confused about these measures too because they're so similar, but one allows LPN visits, and as Chris used to call it, the high cholesterol, the hospice cholesterol measure doesn't allow LPN visits. And also, here's a quiz question. If an RN and social worker make a joint visit, but nobody else visits in the last 3 days, have you met this measure? No, it's days, not visits, and you have to visit 2 days out of 3. Yeah.
Thanks, Barb. Yeah, that is. Yeah.
Is that a typo where it says RN only, not LPN or NP? I mean, don't you have to be an RN to be an NP?
What? I suppose you're right, Dr. Gronkowski. Dr. Bill. Dr. Bill, that's right. If you're an RN who's also an NP, then technically I suppose you could count for that visit. But
Yeah.
it should just say no LPN. Right?
You would have to be visiting as an RN role.
Yes, you would have to be
Yeah.
visiting as an RN, not an NP.
That's true.
That's how the visit is coded.
Yeah.
Well, it just depends. That's a whole nother So I just wanted to, before we leave this whole topic and go on to Kathy's the research slides. So we had a family member tell one of our on-call nurses when she went on a death visit, patient had already died, I just decided to give him the whole bottle
Oh.
of pills because she felt like he was suffering and eased to some. That was a death that had to be reported.
Yeah.
That was suspicious. So you have to go over that and review that with your nursing staff because, not all hospice deaths are quote unquote normal. And so if something seems hinky, it has to be reported. And the medical examiners and coroners are counting on
Right.
when it's appropriate. That's why we have that gift of not having to have our death visits all visited by police.
That's right. Okay. So now let's turn our attention to helping our staff know when to offer a visit at time of death. Okay, so when do we offer a time of death visit? I would say we should always offer, because the families may want that emotional support. Families may want the body to be washed and prepared. It can be a time of closure for the family with hospice, and the facility may request it. We've had that happen with some of our assisted livings. I don't know if you guys have experienced this, but they want a nurse to come out because maybe they don't have anyone that they feel can do this, so they want us to come out and agree or see that the patient has passed away. But as much as we look at that and go, yes, the best practice, we definitely want to offer that time of death, but some families, based on research study that I did, families may not want a time of death visit, and we also want to honor that. We want to honor choice of our families. My research found is that some families do not feel they need it. Maybe if you've been visiting very regularly, maybe you're doing daily visits as you've seen that the patient is dying. Maybe you were just out earlier that day. And when we call and offer the visit at time of death, they may feel like, you know what, I really don't want or need anybody to come back out. We just really want that time, just us. We should honor that as well. And sometimes it's just that they don't understand what the person will do if they come out at time of death. So it's very important to, based on conversations I had when I was doing my research, it's very important that we have these conversations before the time of death happens, and that we educate families, what will we do when we come out? Because really the time to educate is not when the patient has just died, because they're not thinking clearly, and if they were to call your hospice and say, my loved one has died, and you say, oh, well, we can have someone come out, that is not the time that we want to be doing that education about how we can support them and what we can do to prepare their loved one for death, for them to be gone. So we want to make sure we do that. And sometimes families they feel this is their sacred time with their loved one, and they don't want anyone else there. A lot of the people did say, though, that I interviewed, they were more receptive to someone that they knew coming out, like if they had been their hospice case manager. If this was after hours and it was a stranger, somebody they had never met, or on the weekend, they were more likely to say no, because they didn't want someone they didn't know to come at that time. It was a sacred time for them. But just because that we may not go out at the time of death doesn't mean that they still want follow-up from their case manager. Like the next day or the next time their case manager is working. They really do appreciate and want that. Most people want to hear from their case manager, because when we don't call and follow up, the next day or the next day they work, a lot of people said they felt like they were just dropped by hospice. So we definitely we want to honor that moment for them, but we don't want them to feel like we've abandoned them. So it's kind of a fine line with that. And sometimes they feel like they've done everything, and they may not want that visit. However, if we do go out, what should we do? We want to make sure we make those visits meaningful. I did a second study where I looked at what is meaningful for families when we go out. Because if we're going to do the time of death visit, let's make it count when we go. Let's make sure that we are providing the best support that we can to our families, and make sure that we offer something to them that can be meaningful to them and really give them some closure. Because for a lot of people, especially in our states, a lot of people do cremation, and this may be the last time that they're actually looking at their loved one. So we want to think about that as well. So education to families about time of death, as I said, we want to educate well before time. We want to talk about to our families about what they can expect when they call, and what they can expect if they say they do want someone to come out. We can always let them know that we will be coming out, and that some of the things that we can do is we can come out, we can just verify the death if that's what they want. We are the experts. We should be helping to guide our families through the process after death. At Evergreen, we spent some time talking about how to make these time of death visits more meaningful, and we created kits called the Lavender Legacy Kits that we created and put together, where we offer, where we can do, take a little piece of, cut a little part of the loved one's hair and put it in a little vial for them to keep. We can do thumbprints to put on a card so it won't smudge, and it has a beautiful saying on the other side. So it's something that they can keep of their loved one, and that they can use if they wanted to create something from that. Sometimes people will want to create take that thumbprint and create jewelry from that. I have that from both of my parents, and I wear it every single day, and it helps me to feel closer to my parents because I have them with me, as something of them with me all the time. So this is something that we can do also for our families, and I tell you, it's been well received. Our families really have very much appreciated. We've sent extra cards because other family members wanted to have the card with the thumbprint, or they want the vial with the hair as well. We put lavender. We have a little satchels with lavender and a little spray bottle that's lavender, so that we can bathe the patient in the scent of lavender. Now, we recognize not everybody can handle the scent of lavender, so they can, if lavender doesn't work for them, they can use whatever kind of, oil or lotion that they might want to use. But it just gives them an opportunity to do something special to prepare their loved one before the funeral home comes. And our volunteers also have a part in this. They they make these really incredible washcloths that are very, very soft. They're made out of bamboo yarn, and they make these, and they're packaged in these little boxes that we have that we take out. And we had one family, this went on and on about the beautiful and how soft that washcloth was, and it was so meaningful to them to have that. So there are lots of ways that you can make these visits meaningful, and that would be my challenge to all of us, is to do that. Okay, and his reference and questions. These are my dogs, some of my dogs. Any questions? Oh, well, I can tell them. It's like if you had two identical twin kids. Yeah, you can tell them apart. All right, thank you.
I really appreciate Kathy's suggestions for how to make death rituals meaningful for staff, in addition to the families of the patients we serve. I've lost 3 pets in the last 5 or 6 months. I know I have a new puppy, you heard about that. But, I was offered the paw print, a lock of hair, all of that stuff that we don't typically do that. And so I appreciate those suggestions. I think there are things we can do that make it the whole visit more meaningful, and not just about here's how you destroy the meds and whatever it is. Okay, I promise we're gonna get done on time. We are not gonna go over. The set of slides is really dense. I think there's 40 some slides. A lot of them are just for your reference. I'm gonna boil it down for you. CMS doesn't really have any regulations about verbal orders that apply to hospice. Oregon and Washington don't really have anything either about hospice, or not very much, and I will show you what there is for Washington State. So there's not very much. So then you're left with, in fact, what the CMS regulations say a lot of, follow your state or local regulations. And then we don't have anything, right? So what do? So what are you left with? If you're part of a hospital or healthcare system, you might have to follow whatever their policies on verbal orders are, but at least try to get them to understand what some of your constraints are. And if you're not part of a hospital or healthcare system, your choices are wide open. So you have to try to figure out what makes sense to you. So, okay, we'll go through some of these. Again, some of them pretty quickly. I don't have any disclosures. It's a pop quiz, so we're not doing it with poll everywhere. So just true or false, do a shout out, or you can hold up green or red, whatever you want. Our program has a policy about verbal orders. Many programs don't. And my former program, when I was director, I would be such a better hospice director now because I know more. We didn't have a policy on verbal orders. Everyone in our program understands the policy that you do or don't have. Our EMR makes it easy to document verbal orders. Who said yes, and we want to know what it is? Which is it? What program? Epic. Oh, okay, cool. Only an RN can accept a verbal order. False. If a PA issues a verbal order, it must be countersigned by the attending physician. False. But there are many programs that still have a policy, or the staff still think they have to get it co-signed by a physician. And boy, does that piss off the physician assistants. Sorry for my French there, but it's needless because that's not a thing anymore in either state. Okay, verbal orders must be countersigned by the practitioner who issued the order within 30 days. No, false. But some people have that as policy. Verbal orders are only given regarding medication dosage changes. False. Okay, a referral given over the phone is one example of a verbal order. It depends. Maybe. Okay, does a referral for hospice require a physician's order? We covered that this morning. No. But you might have a policy that says it's an oral CTI, Anyway, so who can accept a referral? Anyone can accept a referral, unless you have a policy that limits who can accept a referral. That is your choice, but you might be creating internal barriers by having a policy. So just look at it, how it reads. Now, and I do realize in reality, it might be the politic thing to do if a neighbor referred a patient and that patient does have a community attending physician. As a courtesy, you might want to reach out to that community attending physician because, maybe they're going to get mad if you go in and evaluate them for hospice. So you just sort of, and it varies, from community to community and maybe from physician to physician. But follow your usual process. And in Washington State, one difference, and Oregon doesn't have this rule, and this was a change that happened in 2018. If you accept a referral, and you have to sort of define in your own program what that means, you have 7 days, the clock starts ticking. You have 7 days to go have an RN do the initial RN assessment. Yes? So you would have 2 of your hospice physicians evaluate the patient, or? I can appreciate that was an AAHPM recommendation, but what if you only have 1 hospice doc? Yeah. Anyway, and programs with more than 1 hospice doc might say, we're so busy now, I'm not going to add that extra layer. And really, only 1 hospice physician is required to sign the CTI. So anyway, okay, but I appreciate hearing about that. That's interesting. Okay, Let's move on. In what circumstances do we use verbal orders? You all know this. When we need an order and we need it now, and the practitioner isn't part of our EMR, or it's after hours, all of that stuff. And you're going to change a treatment, you're going to change a medication, you're going to implement wound care, something that you need an order for. All kinds of examples, and we don't have time to talk about it. What are they? So this is an AMA definition of what verbal orders are. I think we all know what they are, so I'm just going to skip over that. This is another view about verbal orders. Again, it's a lot of language. I just provide it for background reference. And then there was an interesting article from the AMA, and I've provided the links for all these. Are verbal orders prohibited? Well, of course they're not prohibited. The EMR hasn't totally eliminated the need for verbal orders. So anyway, you can take a look at that. And here was another AMA article. Is order entry a physician-only electronic health record task? Well, of course not. Anyway, but they have provided some nice resources there. So these are some recommendations for how you would want to set up and create your verbal orders. Again, I'm just providing this mostly as a reference. And what you want to have in your program is this philosophy that it's okay to question verbal orders. It's okay if you don't understand them. I don't know how many in here are married or in a long-term relationship, but communication snafus happen all the time, and they could certainly happen between professional colleagues or physicians calling in an order. So it's okay to ask questions to clarify. And yeah.
It's okay to ask questions. It's not okay not to fill the order.
That's debatable, Dr. Bill.
I think you have to inform the physician at least.
Oh, absolutely. Yes, yes.
For an order to be taken, the physician to expect the order is being carried out, and then the order not being carried out or to be delayed by several days, I think is a violation.
So your point is that if you're not going to carry out the order, the program needs to contact the physician who gave the order, and that's an excellent point. But people do have questions about orders sometimes, and they're not comfortable. So, yeah, yeah. Right. But you want to know if they're not going to carry it out. Yes. If you can, I don't know. I'm assuming your order isn't, that outside the norm or whatever. But anyway. So CMS has some guidance about verbal orders, but it doesn't really apply to hospice. They have some in the hospital manual, and I'm just going to provide that for your reference. And they also have some guidance about verbal orders in the home health agency manual. So if you also provide home health and you use the same staff, the same 5 nurses, including Molly, do both home health and hospice, probably you want your policy to read the same. So you could use this, as a guide, but it does say you want to, have it, your state rules apply. Anyway, okay, so here is, again, more language from the home health agency that says a nurse, qualified therapist, i.e. PT, speech language, OT, or medical social worker can accept verbal orders. So I get emails from people who don't provide home health who say, can a social worker accept a verbal order? And I always think, well, they can in home health, so why couldn't they in hospice? So it's really up to you to decide, and the CMS hospice manual and the state regulations don't really address that. And if you're an LCSW, you can bill Medicare Part B for visits, so you don't really need somebody to be giving you an order in that, in that example. So, and then Oregon state law has a little bit to say about verbal orders. Again, I'm glossing over this. I know I'm going through it quickly because it's not that helpful, frankly, and it's just reference information. Meg, is there a question from one of our virtual attendees?
Thanks. There was, and I'm not sure if it had been answered because I missed it earlier. What if a family declines an RN visit for 2 weeks after the referral? That was a few slides back.
So that actually I think was a previous presentation maybe.
Oh,
I'm sorry.
So sorry.
So basically the RN can't even get out there for the initial RN assessment because the family keeps declining. I think you have to discharge
Okay.
that patient for cause or, right? Oh, right, yes, in the Washington law, yes, I'm sorry. Yes, if there's a documented reason why you're not going out there within 7 days, absolutely. You just document that, what the reason is for the delay. And it could be the physician who gives you the referral and says, I want you to start in 3 weeks after they finish chemo or get their paracentesis done or get their hip replaced or whatever, have their last dialysis treatment, whatever it might be. Yes, if there's a documented reason for the delay, then you can absolutely follow that. Okay, let's see. This is just about what it means to prescribe. And Washington does have a little bit, they have a nursing care, a Quality Assurance Commission advisory opinion, which really isn't state law. Leslie, help me understand. An advisory opinion is just an advisory opinion. It's not really, yeah, it's just guidelines, basically. And it says, Washington state nursing law and rule does not address the use of verbal orders. Well, isn't that helpful? But basically, you can take a look at that. Washington law does have a little bit about using verbal orders under the nursing home statute, so you can use it as a reference if you're, looking at your policy revision. And then Oregon administrative state law only has rules about verbal orders for home health agencies and special inpatient care facilities, which is like inpatient hospice units. There's a little bit about verbal orders in that part. But of course, there aren't very many of those in Oregon, so it's not too helpful. Do the Hospice Oregon administrative rules address verbal orders? Not a word. Okay, and the Oregon State Board of Nursing does provide a framework. They're not going to answer a question, can an RN do this? Can an LPN do this? Who can accept verbal orders? They're going to give you this framework that you have to work through. And it's based, they reference this North Carolina. Now, Kathy Katzenberger is from North Carolina, so I guess, and Marisette's not here right now, but I guess we owe you our thanks for creating this. And again, I'm just providing this for your reference. You can take a look at it. It talks about when a nurse can accept a verbal order, etc. And the Washington Administrative Code does have some language about verbal orders. And it talks, but there's no time frame. The home health rules have some time frames, and I think it's like 60 days. Did someone have a question or comment? 21 days? I think that might be your policy. I don't know that it's in the WAC. And it might be home health. I don't know. You're starting a rumor now about what the... Yeah, sorry. No, this slide is about hospice, and I tried to be clear when I referenced that and where it is. Oh, wait, here it says, return to the agency within 60 days from the date the verbal orders were received. So this language is in all of home care services, so whether it's home health or hospice, I think you have 60 days to get that order signed. So this is just some suggestions for having in your policy language how you want your orders to read, dose, etc., and the process counts. Again, this is just reference information. Who can issue? In the Oregon State Board of Nursing, any licensed independent practitioner can issue orders to a nurse, RN or LPN. So you can take a look at that, and then physician's assistant. And then this is the slide that says PAs don't need to have their orders co-signed. In Washington, PAs don't need to have their orders co-signed. But wait, there's more. Oregon State Board of Nursing also has a list of people who can give recommendations for care to a nurse. So this could be stuff that goes in a care plan update. So anyway, just take it with a grain of salt. And this is in Washington, who can issue orders. I tried to scour everywhere I could, every regulation. I just wanted to provide it for you. Podiatrists could issue an order, a verbal order. Lots of people could give you verbal orders. And then here's this helpful document, who can prescribe and administer medications in Washington State. You can take a look at that. It doesn't really talk about verbal orders that much, but so this is where it gets into the receiver of the verbal order. What's their responsibility is to understand the order they're taking and to make sure they understand it and to ask questions, to get it written down immediately, to not take it while they're driving in the car thinking, well, I'll pull over in half an hour and jot that down. Hopefully they're not doing that. Okay, this one is ridiculous. It's a language about who can receive verbal orders, and it comes down to that CNAs can, but only in certain work settings, not in home health or hospice. And a CMA, a certified medication assistant, cannot accept a verbal order. So, you know, limit who can accept it to therapists or nurses. But wait, there's more. And Washington also has some language about this. Anyway, I'm gonna, I'll let you take a look at that later. Can a PT, OT, speech therapist, a social worker receive a verbal order? Yes, and usually it's not even necessary because all of those therapists have what's called direct practice. They don't even need orders. They can decide. And of course, because this is the 5 W's, who, what, where, when, why, I had to put in a where. Well, it's anywhere you can receive it, right? Anywhere you have cell phone service, sorry. And when, and can we all agree that the CMS guidance, which is really for hospitals, that they should be kept to an absolute minimum? Well, that's not always practical. We are required to provide medications and nursing services and physician services 24/7, 365, not 364, 365. And that involves verbal orders. But if your practitioner has access and can do their own order entry, that's the best, right? And then, the nurse isn't having to write that verbal order. But you have to think about, this is a 24/7 service that we're providing, and sometimes there is an urgency component because you're trying to get symptom control for your patients. So why use them? I think we all know we have to manage symptoms, and we have to manage them all the time, and you have to adjust plans of care. Okay, so here's my person jumping through a hoop. When there's not much hospice-specific guidance, what are you left to do? So again, if you're a hospital-based program or a healthcare system-based program, you're going to model your policy on whatever those policies are. Be sure that your policy reads clearly and all of your clinical staff understand it and make suggestions about how it should read. And don't add any unnecessary hoops or barriers if you can avoid it. Blah, blah, blah. And of course, require your providers who are issuing orders to do their own order entry when they can. Let me see. So what I get sometimes is who can act as an agent of the physician. So here's a compendium of state laws. Sorry for that long link. And it didn't provide a lot of information, but somebody who works in a doctor's office is allowed to act as an agent of that physician and relay verbal orders to you. So we're going to go over our pop quiz. Look, we're going to be done on time. No worries. Okay. Have something changed in your program now has a policy about verbal orders? Everyone in your program now understands the verbal order policy. Your EMR, besides Epic, makes it easy to document verbal orders. And in Washington State, does it track that they're signed within 60 days or 21 days, as it must be the case in Snohomish County? Only an RN can accept a verbal order. That's still false. Okay. Does a PA's verbal order need to be countersigned by someone besides the PA? Absolutely not. Only the PA has to sign their orders. And let me see. Verbal orders must be countersigned by the practitioner who issued them within 30 days. That might have been an old home health rule that went along with that LPN supervisory visit in Oregon. That was 30 days. And of course, verbal orders are given for lots more stuff than medication dosage changes. Referral given over the phone might be, I don't think we need to cover that again. Here's my 3 East Coast grandsons paying attention to me, their grandma, when I was visiting. Thank you all for your attention. And we are at break. You know, I wonder, let me address that because otherwise, what those guys did was they brought but, you know, you'll be able to stand here and advance your slides. I'm gonna do a few introductory, but then let you advance.
I have to stand up here. I was hoping to talk
or
from
you
over
could
there
sit.
with everybody. but the issue is
Check.
you can't see.
Check, check, check. Check, check, check. 1, 2, 1, 2. Hey, hey. Check, check, check. Check, 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 check.
Well,
Check, check, check. 1, 2, 1, 2.
Yeah, you're gonna sit there.
Hey, hey.
You would
No,
have
no,
to
no,
have
no.
your laptop, so you would advance
have
the
that.
slides for,
Okay. All right. Fair enough. That works.
we'll give you the power.
Tracy had to go to another meeting, so she's not going to be. I was going to have her do the clicker from out there. She paid.
Stacy Jones, come on down. Yes. Welcome back, everybody. Hey, we're on the home stretch. 2 Fit in 30 sessions left. And then there's a brief adjournment and no host happy hour. I mean, free food. No host bar, but free food. Reception. Is it? And it's starting at 5, not 4:30. Is that right, Meg? 5. Okay, so you get an opportunity to go for a walk. So this is our CTI and admission challenges. So, and then we have a different panel. Except Molly, are you back up here? You are. Yeah. Poor Molly. Molly mentioned to me she was retiring later this year. So I said, Molly.
And I'm looking for a replacement.
Why don't you come?
Unique opportunity.
Honey, buy an exhibitor booth if you want to recruit. So I said, Molly, come and share some of your interesting stories, because she shares these stories with me sometimes, and they are unique and interesting. So anyway, so Molly agreed because, I don't know, she didn't realize what she was signing up for. And Stacy is a gracious fill-in for her colleague, Penny Smith. Who knows Nurse Penny on Instagram or Twitter or something? She's on social media. She has like 100,000 followers or something like that. And she got too busy with her schedule to be able to, she was going to present virtually and said, oh, I'm drowning. Maybe Stacy will fill in. No.
Sorry, so you're stuck with me. She's much cooler than
No.
me.
She said, Stacy should be able to talk about this complex case management. So where's Leslie Emmerich? I was going to tease her. Oh, she's missing. She asked me what CTI stands for. Does everybody know what CTI stands for? Okay. Yeah. Let's tease her when she comes back in. All right. So anyway, so no disclosures. Let me see. The usual. So these are the learning objectives and our font of CMS knowledge. So has this ever happened to you? I have a few introductory slides here before we get to hear from the real life providers. You get a referral for a new hospice patient and the patient doesn't have a community attending physician. Yes. I actually don't have an attending physician. My physician left town last July and it's taken until next month for me to get a new attending physician. Leslie Emmerich, what does CTI stand for? I was teasing you. It's not a political term, or you would have known it. Yeah, exactly. Okay. Or you get a referral and the patient hasn't seen a local physician recently, like maybe it was 5 years ago. These things happen, right? Or the patient does have a community attending physician and this person, you know, your staff know, is not prompt about getting back to you about whether they want to be involved in this patient's hospice care and serve as the community attending. It happens all the time. So, and there's a reason why these questions are in a gray area. Here's a sort of it's not a quiz, it's just consideration questions. Can a hospitalist ever be a patient's attending physician? Actually, in my community of Corvallis, Oregon, I'm looking at Amy and Tracy, there is a resident clinic, and some of those residents also serve as hospitalists sometimes, and they see patients in a clinic. So the answer isn't black and white always. So, and a hospitalist, it could be if they're the person who knows the patient to the best and they're going to be around, especially if the patient's only going to live a week, and they're like, yeah, I can be available for this patient. So it's not black or white. Generally, hospitalists would not be likely candidates, but there can be some rare exceptions, so I just wanted to point those out. And can a resident be a patient's attending physician? Yes. Residents are fully licensed physicians. And like I said, in my community, there's a residence clinic. They're there for 3 or 4 years. They have a caseload of patients, and they absolutely could be an attending physician. Can a medical student be a patient's attending physician? That's the trick question. No, they're not licensed as a physician. But sometimes our staff don't understand, and I just say this from experience, the difference between, they think a resident maybe isn't a full-fledged physician, so sometimes you just have to remind them. Can an out-of-state physician ever be the patient's attending physician? Yes, that's right, because the VA has physicians that are sort of licensed nationally, so it depends. Generally, the CMS COPs say the hospice physician has to be licensed in the state where the patient is receiving care. But there are some exceptions, like the VA physicians. Can a community nurse practitioner be the patient's attending physician? This NP is not employed by the hospice. Yes. Can a community physician assistant be the patient's attending physician? That's more recent. That's just been in the last few years. The NP rule was issued in 2003, but sometimes people don't, think about that. And I said which one of these is a trick question. Of course, it was the medical student question. What does CMS seem to think about attending physicians? And I put this slide in because Judy Lund-Person sometimes refers to, who knows who that doctor is on the left side? I'm dating myself. Marcus Welby, of course. Katie and Rochelle would know who Marcus Welby is. But the CMS rules are written sort of like it's still the 60s or 70s. I think the show was actually on right in the early 70s. And they think that that attending physician is always available 24/7, 365, right? And that the same physician who issues the oral CTI should always be available to sign the written CTI. And that's just not real life. So the real definition of who can certify a patient, it does have to be a physician. So that could be an MD or a DO. I don't know, are there lots of DOs in Washington State? I know there's a DO school in Yakima, but we're getting a lot of DOs in Oregon because of the DO school in Lebanon. A lot more, yeah. Okay. Let me see. And is identified by the individual as the person who is, most in control of their care, most familiar with their care. Let me see. This is that regulation about state licensure. The CMS COPs do require it, that the person is licensed in the state in which he or she performs that function or action where the patient receives care. And it gets tricky. Some of you cover 2 states, and that can be tricky. So your physician has to be licensed in both states, and your nurses and your social worker, all your people have to be licensed in both states. So anyway, but this is about CTIs. So rights of the patient, again, this is the COP that has to do with the patient having the choice of attending, and of course that has to be documented on the election form. And then in the time frame, in the interpretive standards, the Appendix M manual, it says this: if the attending physician is unavailable or unresponsive, the hospice physician must assume the role. So many of you remember Corinne Ball from NGS. She was the NGS educator. Boy, we miss her because there hasn't been a great person. No offense to Shelley Daly, who was here last year, but Corinne Ball was just a good educator. And she would say, if you haven't heard back from that community attending physician by the end of the 3rd day, that patient doesn't have an attending physician, and your hospice medical director must assume that role. And so there are various ways that you can document receiving the oral CTI. You want to make sure that your hospice staff are entering it into the medical record in a place where you can find it later. If there's an audit, you want to be able to prove that you received that oral CTI. Blah, blah. Let's see. And other oral CTI documentation considerations. This comes down to your program policy. Who is allowed to receive the oral CTI? it could be anybody in your office, right? Does it have to be an RN? I mean, it depends on your program policy and your perspectives, but it doesn't have to be an RN. And during this time of workforce shortages, do you want to require RNs to do things that maybe they don't have to do? So again, it just comes back to your program policy. Who's allowed to give you an oral CTI? Could it be an agent of the physician at the physician's office? Happens all the time, right? So, okay. So then you have to decide where in the medical record you document the oral CTI. And again, you want to be able to find it later if you need to. And do you have a policy, procedure, or policy about this so everybody understands where that oral CTI gets documented? I think it was more haphazard perhaps in the era of paper charts when it could have been on a Post-it note for that matter. And you're trying to make it look real. So can anybody give me an example from your various EMRs where you document the oral CTI? Does it go in orders or does it go in, miscellaneous? Do you have a tab, an electronic tab for oral CTI? Yes. Anybody else? What? Admission notes? Okay. Anybody else? Still figuring it out, or you just don't want to share? Okay. And can you easily find this documentation later, should a question or an audit come up? Okay. What do you do when you're asked to admit a patient to your hospice program? So we're shifting from CTI challenges to admission challenges, and the home isn't safe for your staff. The home isn't safe for the patient. The patient lives alone, doesn't have or want a caregiver, but still wants hospice. And do you review your policy about requiring a caregiver at some point with that patient? Does CMS or the state require you to admit this patient? No, absolutely not. And that's frustrating to some referral sources because they think you should be required to admit the patient. But you are entitled to have your admission criteria. And I have visited patients in homes, one who lived in a garage and one who lived in homes like this. And I'm sure many of you have as well. Okay, so we're going to talk about some real-life challenges and how these programs meet them, just some admission challenges, not CTI challenges necessarily, unless you want to go there. So I don't know if you flipped a coin or you want to. Stacy wants to share about her complex case review, but I made Molly go last time, so if you wanted to go first.
I don't, okay, fine. I have a better defense than offense, let me tell you. So I think the admission challenges I've been running into lately, transfusion, we've had that twice in the last month. One of them is a VA patient, and the VA said, yeah, we'll pay for his transfusions. And so he's still going to his oncologist and gets transfused, and I don't know what tests they do, but the VA is paying for it. And we never see any of those results. The only reason we even know he's getting them is he says he's getting them. So it just seems so odd that we're not really in the loop. But, I've been talked off the cliff a few times, so I'm okay with that. And then the latest one was a 35-year-old fellow that's been living in Pennsylvania that wants to come home to die, and to our little town of Heppner, and wanted to know if he could get transfusions. And so that's been a real struggle because I've known this young man his entire life. I know his family. I told Barb every one of his family, well, his dad's, I don't know his dad's on Facebook, but his two sisters, him and his mother, we're all Facebook friends just because, it's a small community and that's how we find out about stuff, So, because we don't really have good news, radio, or newspaper. So that's one of the current issues with us. And then the other one is sometimes our case managers that make the referrals have very unrealistic expectations. which I'm sure every one of you run into, and if you can't have the equipment there by today, which of course, you know, just as soon as I say, no, we can't, I'm sure they won't be able to deliver it till Monday, then you call the DME and they say, oh yeah, we can have it there today. Oh, whatever. You know, so, you know, you never know what's gonna happen. But, and then the other one, because we're so isolated, like some of our, you know, people are a couple hours from a pharmacy that we can access on weekends, not sending them home with enough meds. And, you know, their pat answer is, well, hospice will take care of that. Well, yikes. You know, we need enough to get through at least 3 or 4 days. So don't be so darn stingy. Come on. But that would be my top 3.
And just a question about the transfusions, Molly. So that is not a treatment that you guys usually cover on your hospice program, right?
Correct.
So the VA was willing to cover it and carve it out, but the second referral, that's not necessarily the case, right? And the Philadelphia social
Well, I didn't
worker-
tell you the caveat that happened after all this, because I included my my hospital CEO on all these emails. I just CC'd her, and I don't usually do that, but I thought sometimes she kind of needs to know what is going on down here that's taken up. You know, we say we're so busy. Well, this is what we're so busy doing. And so the IDG team decided, no, we can't do it, and we offered him a couple alternatives. And so I was kind of reviewing it with my CEO on Friday, and she said, Molly, I think we should cover it. I'm like,
And this is a weekly transfusion that
Well,
would cost $1,500?
about $1,500 in our facility.
And they have an average daily census of? 6.
that's
So we're talking stewardship here, and
Yeah.
staff time, and, yeah.
So what actually ended up happening is the CEO trumped it, and she said, you know, this is a local, I mean, it's not that it's so local, but this is all our, it's all our money. It's, the hospital's the same as you guys, so we'll just go ahead and do it when he needs it. And I don't know if he's gonna need it weekly.
Okay.
But,
But back there, he was getting.
yeah, so I called the mother, and I get a little teary. Yeah. And she started crying. So, and of course, I start crying.
Oh, gosh. Well, you've known him since he was a baby. Yeah. Right, yeah.
Yeah.
So sometimes the admission challenges are that you're being asked to cover something that really is beyond your means to cover. I mean, I guess it's a good thing that the hospital CEO stepped in and said, your money is our money, we'll cover it. You might have to remind her of that later.
I'm sure we'll get the bill.
Yeah.
So,
And you can say
Yeah.
you're paying it.
Yeah.
you can try that.
So I think everybody in this room can relate to being asked to cover an extraordinary procedure, and it gets into, is it palliative or is it life prolonging? You know, you would, I suppose you could make the argument
The
either
patient
way.
admitted, well, you know, it really just helps him to have more energy. But he told his mother that one way or the other, he was coming home.
Yeah.
And if that means he dies earlier, he dies earlier.
Yeah, gosh. It's much harder when you know the patient and the family, right? I mean, that's, yeah, it's much
How is
easier
that
to be
for a lead?
objective when it's, you know, a patient, not your friends. Yeah. Yeah. Katie's suggesting maybe there's a community fundraiser that could be.
You know, Katie, I don't know if I want even that to get out.
Yeah.
That we're doing that, because it's like, that's my big concern.
Yeah.
Oh, boy, we can't offer this for everybody, now you've opened this door.
Yeah,
And
yeah.
I'm not sure I like the door being open.
Yeah, well,
And,
yeah,
you know,
it's a
these are
challenge.
people that are, you know, his mother runs the community Facebook page. That's how we kind of get our news, really. I mean, it's
Because
kinda-
you don't have a newspaper in Hebner,
Well, we have a
right?
weekly.
Oh, yeah.
But sometimes it's spelled with an A in it, so.
This is why I invited Molly Ray to be a panelist here. Gosh. All right. Well, Stacy Jones, take us through your complex case assessment, pre-assessment, and how you would have dealt with this request to do weekly transfusions for a 35-year-old patient, maybe on Medicaid.
Yes, well, Molly, I really appreciate you. And gosh, what you do with a very small hospice, I'm sure you have to make a lot of hard decisions. And I also want to appreciate Care Partners, I believe, who was talking about their review prior to admission. You know, I think thinking about kind of the things that you were saying, right? How do you remove barriers and increase communication about issues and concerns before they hit the care team, right? To give them the heads up. So that's what we're really trying to do with this process that we put in place. And I also liked what Dr. Bill said about sometimes you do need to take a pause, right? And not just quickly admit these complicated patients, right? We get a lot of patients that we would call easy hospice patients, right? That you can just quickly move to admission and everything's gonna go well and everything's gonna go great. But then you have these very complex situations where you need to think about them a little bit before you admit them. So a couple of things that we have put in place prior to admission. So we have a marketing team, a business development team, and some of them are clinical. So we have some nurses, we have some social workers, but we also have staff who are not clinicians, right? So we want to give them some guidance to know where to go with a referral based on their diagnosis, based on their patient situation. So the first thing that we have put together is what we call our palliative treatment guidelines, right? So those are those things that, you know, a typical hospice patient may not get, we may not cover. We could cover though, and so giving them guidelines on, okay, this is always gonna be approved, or hey, these are things that we take case by case. And so giving them just basically a guideline, a list of, okay, like a G-tube, right? We're gonna cover patients who have G-tubes whose that's their only source of nutrition. Yet these are the only types of feedings that we cover that are on our formulary, right? So to really give them some guidance and some nuance into different situations, because we won't cover every type of formula, right? You guys know there's some new formulas out there that cost lots and lots of money. And I'm sure you've been asked to cover them. So that's the first thing that we've done, is give some guidance to them, and it really helps those liaisons, those marketing people that don't have a background in clinical care, right? Who don't have the clinical judgment of a clinician. So then the next thing we put together is what we call our pre-screening tool. And that not only covers we have a section that's medical complexity, and it talks about things from a medical standpoint that, hey, you want to give the heads up that this is going on with the patient, right? So they're coming on and we're going to cover the dialysis. They have a tracheostomy, they have a ventilator, right? Those things that you don't want the clinicians to the care team to be surprised about that. Then we have a section that talks about the home environment and the psychosocial situation, right? And so we have a bunch of things that if they see these things or these are a concern, they need to bring it up to us, right? And to let us know. So things like active or recent substance abuse, inadequate caregiving support. It's not that we're not gonna admit the patient, but need to know about those things. And then if any of these things are present, what we do is we ask them to write a note, just an informational note, or if they're like, we really need to have that conversation, like Care Partners was talking about, they write an SBAR, right, with the recommendation to have a complex case review. And then we'll have a complex case review prior to the admit, talk through those things, make sure we can care for the patient safely, make sure we have a good plan in place. Often we'll invite the care team that we know that's going to get the patient to be there to know what's happening. So, yeah.
So can I just ask, and I'll pick on Tracy Villarreal too, how long might your delay be in admitting if you have to do this complex case review? And Tracy, I don't know if I asked this precisely, come on down or share there how long it might take and how your staff feel about saying they go out to admit a patient and then they find a completely different picture and they might have to say, you know, this needs to go to our care team to talk about. You know, how long is that delay typically?
We try to close the gap and make that happen fairly quickly. So if for some reason we do get caught off guard pre-admit and the person goes out and says, uh-oh,
yeah,
press pause,
help,
we'll try to, you know, grab some group together that same day, right? Maybe not while the admission nurse is in the home, but when they get done with their visit, like they get on the call with us. Here's what I saw that maybe you weren't aware of, or that kind of thing, so that we can, you know, reschedule another admission if we need to. That's an actual admission, or to work through that problem. But we try to minimize the amount of time because the family and patient are looking for answers too.
Oh,
and we
of course,
understand that.
yeah. And you have to give staff scripting, right, to say, you know, we'll get back to you as quickly as we can, but we want to provide you the most information because they want to know, is this going to be covered?
Well, and we also want to let our referral sources know, right? If it isn't looking like this is something that can happen quickly, we want them to understand our reasoning and make their own decision about how they want to proceed, or if they want to keep working with it together, then we do that. So.
And is it ever, oh, sorry.
I was just going to say, and I don't know about you, again, sometimes we invite the referral source to the complex case review because they have a lot of the information that's needed, right, about the situation.
Yeah.
And ours is similar to yours. You know, we try and admit same day, next day, if at all possible for any patient, right? And this can maybe delay it for a day or two, right? Again, like you, we try and get that complex case review set up as quickly as possible.
And is it ever the case that these patients, maybe their next option is to try to go on home health if they have a skilled need? And get something, you know, in the interim, because they're probably saying, well, what do we do if you guys say no? And they could go to another hospice provider, although in many counties in Washington State, there's only one hospice provider, but that's not usually the case.
Well, and if it's a patient safety issue or staff safety issue, right, then there may not be another provider that wants to work with that either. And so then really what you're doing is trying to work with that provider to say, how do we mitigate those safety risks? And sometimes that does take a little more time to put things into place to mitigate those risks. So
thank you.
Yeah, recently we also had a patient sent, you know, a referral sent for a patient who needed daily wound care. It was very aggressive, right? And so really talking to the provider about, is hospice really the right place right now? You know, we can't commit to sending a nurse out there daily, twice a day to do these wound care. Maybe this is a home health patient. Maybe that, you know, they need to stay in the hospital a little bit longer till that's managed a little bit better. Or are they really hospice appropriate, and let's look at a more palliative care approach to their wounds, right?
Yeah. So is it easier to triage, and this would be true for both of you, because you also have a home health department, right? Whereas Tracy doesn't have an associated home health department, so you can just shift them to home health within your own program.
Correct.
And that's an option, and that's more of a challenge for standalone hospice programs. Yeah, absolutely. Thank you, Tracy. Questions for our group, and I know we maybe just have a couple minutes left before we switch to discharge dilemmas. And Molly gets to stay up here because she's got those kinds of stories too, as you can imagine. Anybody have any, or do you want to share an admission dilemma of or challenge of your own? Anybody? All right, they're seeing the end is in sight. So
Yes.
thank you to our panelists. And now we will welcome our Discharge Dilemmas crew.
We've updated it.
So I asked some folks to share some discharge challenges, dilemmas, and we have Chris and Denise from Kaiser, Washington and Seattle, and of course Molly from Heppner again. And Tracy Calhoun is joining us from Lumina Hospice and Palliative Care in Corvallis. And of course, you all met Tracy earlier today when she won the Wessinger Award. So we'll switch to just covering, nobody has any disclosures, but I thought I'd put that they're all graduates of the College of Hard Knocks because they've learned about these challenges the hard way. So a dilemma, of course, means there's no answer that you really feel good about, right? It's like, which is the lesser evil? So we're going to talk about some challenging discharge situations. So a hospice discharge, this comes right out of the CMS manual. Usually it's discharge due to death, but they could decide to revoke or they could transfer, and then that's become very problematic since last July of 2022, and there can't be a gap at all. And then they could move totally out of your geographic area, or they improve and they're no longer eligible for the hospice benefit. And of course, discharge for cause is another reason. And let's talk about that because that is such a challenge to discharge for cause. And we've talked about this a little bit earlier today. You guys do so many gyrations to keep patients on service. You know, you're always all about keeping patients on service. And so these are the official reasons why you can discharge for cause. And you have to also document all of these gyrations. You've tried a contract. You've educated them. You've let the attending physician know about the issue if there is one, yada, yada. You've tried everything you can. And then you, after the fact, you have to notify both NGS and the state survey office. So this is the quiz. Which type of discharge is the most challenging? Discharge due to no longer being terminally ill is A. That should be a happy time. They're graduating, right? Discharge for cause. Revocation, that's their choice. You got to honor it. All of the above. Which one? Anybody have an opinion? There's no right or wrong answer. It depends on the most recent situation, right? So, discharge due to no longer being terminally ill. First of all, does the patient always agree? No. Does the family always agree? Especially no, right? And are people always excited about graduating for hospice, even if you throw them a graduation ceremony? No. Balloons? No. How often do they appeal your discharge to the QIO? That happens, right? And as we learned earlier, you don't have to stay involved even if the QIO goes against you. So anyway, okay, let's see. And we've already talked about this. You don't have to keep the patient on service. If your hospice medical director or physician sees the QIO response, they could rethink, but they don't have to because they've already thought about it and made the decision. So you are able to discharge, and then you can refer them to other healthcare providers. Discharge for cause challenges. First of all, do you have to deliver that notice of Medicare non-coverage form? No. You're not going to take them back, right? And you need to get out of there now sometimes. So what do you do if the patient and family won't answer your calls? This happens all the time. They're like passive aggressive. Well, They have to keep me on if I don't answer the phone or answer the door. I've heard from some of you that you try to deliver it in person and they won't answer the door. So you can deliver it in writing. You could send it certified mail. Could you be accused of patient abandonment? No. You've already tried to work with them, right? You've tried these steps that you're supposed to do, and you've documented that, and you've gotten a copy of the behavioral contract that they will or won't sign. You've tried all those things. And you have notified them of other resources for obtaining health care, and that could be the closest hospital and emergency room or the closest urgent care, or if they have an attending physician, you're referring them back to their attending physician. So it's not abandonment, you're providing advance notice, and you're providing other resources to them. Okay, let's see. So we've got our colleagues here who are going to share some case studies with us. And are you guys going first? I'm going to turn the clicker over. All right. Who's taking over? Chris, is that you?
Yeah, I think I figured out that I can see it from there.
Let's just go down the other side.
Okay, so let's see here. I'm gonna do this.
I had put it on your cover slide, so I don't know if that's still up.
Yeah, I think this will work. So we had a patient refuse some critical safety elements of the treatment plan, and we had to determine whether or not to make a discharge for cause. You'll see a couple of things. I'll give you some background here on the next slide.
They want you to hold it closer.
Closer? Okay. On the next slide, you'll see some background. There are several reasons we ended up discharging them for cause, but there were really there was a question about potential patient abandonment, like Barb just mentioned, and so let's see here. So a little bit of background. This was a 94-year-old with just on service a couple, 2 or 3 weeks. It looks like 3 weeks. And primary diagnosis was endocarditis. Had some malnutrition as well, dysphagia, and diabetes. They were decisional, and that's a really key component here. They were bedbound and had severe bowel incontinence, multiple areas of skin breakdown, including a stage 3 pressure ulcer. They did have a few episodes of making inappropriate sexual comments to staff, I think on 2 different occasions. There was evidence of actively drinking alcohol during a few of the visits. Refusing all incontinence care from either staff or they did have family who were willing and able to provide the patient's needs, but the patient was refusing that care. We ended up having multiple care conferences, which included the frontline staff, the clinical team, and our risk management department. One of the reasons why risk management was asked to come was because of a patient abandonment concern that we had related to, would you discharge somebody just because they weren't following certain pieces of the plan of care? So I know I mentioned that there were a few sexual comments that made staff uncomfortable. There were a few episodes of drinking alcohol. Those were, when you read that, you think, oh gosh, we can discharge them for cause for that easily. But those were really mild examples, and that wasn't the driving behavior actually in this decision-making process. It contributed to it. It made it a little easier to finally make that decision to discharge for cause. But if you kind of remove those 2 elements, understanding that they were on the mild side of things, and I just wanted you guys to think a little bit about if those weren't there and this patient were just not allowing somebody to clean them up and they were going into a state of maybe sepsis or infection issues and your staff felt uncomfortable providing such an unsafe type of care. We had nurses on the team who were concerned about their own licensure, allowing a case like this to go on and participating in it in some way. So that's kind of where we struggled a little bit was, you know, there's different kinds of noncompliance. I mean, you have medication noncompliance. Would you discharge a patient just because they weren't taking a medication that was on their hospice plan of care? Probably not. We would view that more as patient choice. But when they're choosing things around their care, not to let us to clean them up at all, and coming back the next day or 2 days later and all the messes in the bed, and the family's frustrated because the patient won't let them clean them up. It just was kind of a difficult decision-making process. Oh, let me back up. So we did develop a contract that talked about how often he should allow us to, or somebody, and we gave them options. It could be us, it could be your family members, anybody could help do this. And he did agree to, and sign that contract. And we said that if they don't allow it at least once a day, then we would consider him for discharge. And of course, we documented all these things and all these meetings. I mentioned the staff licensure concerns. So ultimately, we decided to discharge for cause. But it would be interesting to hear if anybody in the room has any thoughts about if you took away the drinking part and took away the sexual misconduct part, just because the patient wouldn't allow you to provide care that would prevent worsening of an infection, would you discharge him for cause? I'd just be curious to know if that would stand on its own.
Anybody?
I would say we've gone both ways. I can think of examples where we discharged for cause and other examples where the team sort of labored on in much less than ideal circumstances. And I'm not saying that one is right and the other is wrong. These are some of the hardest decisions we have to make.
And I'm sorry, Meg is saying we have to, well, and our next speaker is at the microphone, but I don't know, Chris, if you could restate, Providence, Portland has done both ways, if you
So Providence, Portland has done it both ways. You have a comment?
My only argument would be, and I've been in the similar situations, and I can't speak to the licensure thing, but this patient needs us more than anybody. If we hang in there, I mean, and I had a surveyor tell me this one time. It is their plan of care, so they can't be non-compliant with the plan of care that they actually direct and drive. It's their choice. So, and that's what the surveyor told me when we went through a situation like this. Well, we did discharge for cause, and it came around, and there was a lot of stuff, and ultimately, it was CMS. It was in the Midwest, Oklahoma, and the surveyor said, literally, it's their plan of care. They have the final say on what their plan of care is, so they can't technically be non-compliant with their own plan because they're making it. So that was the response we got, and so we kind of let that drive our policy going forward. I mean, after that, we just stuck with them and documented all the attempts.
So, Chris, can I just ask, what was your hospice providing if this patient wouldn't let your staff touch him? What were they providing for the? It was wound care, but I thought the patient wasn't allowing you to provide the wound care.
He wasn't allowing us to provide the wound care, but that's what our main,
Okay, so he's not allowing them to do the wound care. So, I mean, like, were there medications or was there equipment or, you know, really what benefit was the patient getting from hospice if he would not allow your staff to touch him?
It's a great question, and I'm not sure I can answer it because we weren't part of the care team. We were consulted to weigh in on would this be okay for the team to discharge for cause. And it's been a little while since we've had the conversation, so I can't remember the other things that were going on. I'm making an assumption there was something else around some other symptom management beyond the wound care, but I don't remember the details.
Okay.
Yeah. Sorry, do you have more slides? No, that was it. Just a difficult dilemma.
Yeah.
I was curious, with APS involvement, what was their involvement in all of this?
Yeah, I think we might have left that off the slide. There were multiple reports, and this family had a history of APS reporting for different reasons over time prior to hospice coming on board. So there was a lot of dysfunction involved, and yes, we documented different outreaches to different agencies, including APS.
I think your RNs had a legitimate concern about their licenses and also enabling this behavior if you kept him on service and allowed him to continue this where he wasn't letting your staff touch them. And granted, I spent 20 years as a certified wound care nurse, so I absolutely could not live with that situation of not being able to ever do the wound care. And I'm not sure once a day wouldn't have been enough for a cleanup, you know, but I do think there's legitimate reason, and you have to ask yourself, what are we providing, what are we enabling, and we maybe need to stop so we can refer to APS and they will consider this an emergent situation because we're no longer involved. Because probably APS, they're so overloaded and bombarded, right? And they're like, well, hospice is involved, so it's okay, we can get to that one later. I don't know. Anyway, again, with the dilemma, there's no happy end. Can you tell us what happened? Do you know what happened with this patient?
I don't know what happened since. He's
I
not
thought
been
maybe-
re-referred, I know
I
that.
think maybe since he was a Kaiser patient, you might have somehow heard in the Kaiser tree. Okay.
Well, and I don't know about y'all, but it seems, my experience with APS referrals, we have some current ones right now as well. I don't know how extreme it has to be for that. I mean, we're documenting that we're doing it, we're required, but it sure doesn't feel helpful for the situations that I've been in all my years in both states.
Tracy, do you want to segue to your discharge dilemma now that we've solved that one?
Discharge dilemmas. You know, people don't buy into our whole "you're graduating" kind of thing, do they? They sure don't. But we had to actually discharge a patient last year for, she had decided she was going to go to Tennessee to see family members to say her goodbyes. Now, just by looking at her, it probably wasn't a good idea. And she was on Coumadin. I've been checking her INRs wildly all over the place. Because they were driving instead of going just to one place where it's a little easier to arrange a contract for transfer, they decided we're going to discharge, but they did it overnight. I mean, it was planned for a week from then, get all the meds, get everything in place, make sure that she had enough, because we weren't going to take her emergency kit. We were going to let her take that. Her PCP had arranged that. But they decided that next day they were going to just hop in the car and go. So we got out there to discharge. The next day I got a call from the Spokane Police Department to have a discussion about this patient who had my card on her, who died. Not unexpectedly at all. It was actually expected, and I had warned them that this may not be pretty. She was a cancer patient. And the sister who they were going to see in Spokane, and apparently what I was told is they're picking the sister up and driving to Tennessee with this other daughter. Nobody had told that sister in Spokane, and she dropped dead in her home. So, discharge is going wrong. You know, you do the best you can. That just, when I was thinking of my discharge stuff, that was the most recent that was just heartbreaking. Hopefully she died peacefully, I don't know. But it was interesting to have to make a report. I had to give a report to the PD.
Did they?
I had very detailed report for him too. He did express how much I seemed to have known.
Did they question you about her discharge, her e-kit that went with her? I mean, did that have any connection?
That didn't, no.
Okay.
No, that didn't. She had taken it out of the e-kit, so she had just the individual medications.
Hi, I'm just kind of curious about the rationale behind a discharge for cause versus having the patient revoke. If you could share a little bit about that.
You know, she ended up revoking, but we were working on it wasn't discharge for cause, but we were working toward just a planned discharge.
Because she was moving out of your service area.
Right, she wasn't going to be anywhere in the service area, so we knew that we couldn't cover her, and we couldn't cover her because they didn't even have it, right. I mean, who knows how long it was going to take, because she didn't tolerate sitting in a car very long, so I didn't think she'd make it to Tennessee. So we had it planned. You know, so we even planned, I don't think it was a good idea. And then certainly she did end up revoking because somehow I'm not sure, somehow we got the paperwork signed. It was just chaos, just, you know.
You met her on
chaos.
I-5.
You're not going to make Spokane. You know, and it's just, we're always like, you know, you all know, we're at the whim of people's hopes and dreams and fantasies of being able to say their goodbyes, whatever it might be, and then keeping us when we are, you all know, it's well known that when we have a hospice team involved that we provide good care, help their quality of life improve, and then when we do have to discharge for cause, say they're smoking with their oxygen and they've got burns up their nose, or just they have done better than anyone would expect. And then we know how many times that they're coming right back on not long after they don't have all of those layers of support. That's hard for us, but we still have to, you're graduating, yay. Medicare says, you're not appropriate anymore, sign here. I hate those. I just hate it. I just had to do one. The other thing that I don't know if you all are running into, at least in Oregon, it's gotten really hard to get DME in place now. It used to be way easier back in the day to get DME for our patients who are discharging. Because now they have to have a face-to-face visit, at least in Oregon, or I don't know if it's national, a face-to-face visit to get even a wheelchair for my wheelchair-bound lady to go downstairs to eat. So we've had to delay that discharge for a couple of days. Just simple little things like that. Why does everything have to be so hard?
Yeah, exactly.
We had a person in respite, and like I said, I'm one of the nurses also, so I was over in Condon, which is about an hour away, and I get notified that this patient's family, who was believing that if they just prayed hard enough, I mean, not his immediate family, his wife and daughter needed a break. He was on respite. The sister, you know, told him he didn't have cancer. He wasn't dying of cancer. He didn't have cancer. And so we didn't know the sister was showing up. I got the call that sister's here taking him to Idaho. And I mean, I can drive that 45 miles faster than a lot of people. But I did not get back in time, and she was gone. They were gone. And they went to Idaho. She did not hook him up with another hospice. He did not have his medications. It was, I mean, we only got it third hand from the family, but it was like a wreck. I was so angry because our respite is at our hospital. I mean, come on, guys. You don't just say, there you go. They did give him all his meds that he came in with, but, you know, this was a very disorganized, painful death, and APS in Idaho was involved. It's just crazy sometimes, but, you know, he did have cancer. He was dying.
Molly, can you also share the story you shared with me probably a couple years ago now about your patient whose daughter was the caregiver, and then you had to try to find placement for your patient?
Yeah, one of our patients, her daughter was murdered, at the daughter's home. At least it wasn't at the patient's home. And that was the plan. She was the caregiver. And we were already concerned about the caregiving situation. It was going to be a little loosey-goosey. But, you know, the patient had lived alone for a long time, and she was very comfortable being alone. And so, okay, I mean, I can't help it if daughter's not going to be there 24/7. But the daughter was murdered. It was right before Christmas. And we ended up having to get her, you know, obviously into a different situation, which was tricky. So it actually was kind of made a little bit easier because right before the murder happened, the patient had fallen and broken a hip. And so she was actually in the hospital with a broken hip, which we kind of talked about what caused the break. But she got transferred to Portland for some reason. I mean, for one thing, we're such a small hospital, we don't do surgery at all. So we're really good at figuring out who needs to be transferred. And so she got transferred, but, you know, it was just like, wow, that was, and our little town doesn't get many murders. I think I know of 2 in my lifetime. So in the Brugge,
So the broken hip ended up being a blessing because
a
the
little
patient
bit,
was
because she already had to go somewhere. She wasn't going to be able to come home after that, one way or the other.
Yeah. Great. Does anybody want to share any discharge dilemma stories real quick? I know we're almost at the end here. Please, Christina. And Rochelle has one. Whoever gets to the microphone first.
Hopefully mine will be quick. So it's not a fun story, but just a compliance question around discharge for those folks that are graduating hospice. And recently I heard a webinar where the presenter was saying that CMS is now denying payment instantaneously as soon as the word stable or not declining as expected for a hospice, blah, blah, is in that chart. And I think we've always been told at conferences like this that some undefined period of time for coordination of care is appropriate, and we have been billing Medicare for that coordination of care time. And now we're nervous, and I'm wondering.
That is such a great question for our speaker tomorrow, Judy Lund-Person.
No, it's probably all Judy all the time.
Yeah, because I think we've assumed we have a week or two. CMS has never really said, but you just kind of assumed. All right, Christina.
Okay, so this was back with my last hospice, and we did peds, and we had an 18-month-old whose parents were estranged and had criminal cases against each other, restraining orders. And one lived in part of our service area, one lived just outside of our service area. They would go back and forth, transferring between grandparents, etc. We got a call one day from the dad. He had decided to take the baby to the coast for the weekend. And he didn't have her meds. And these were compound only done at OHSU. It was a Saturday evening. And we couldn't safely provide her care, right? And so it's like, what do we do? What do we do? We didn't have a travel contract, of course, because the coast doesn't have anybody who's doing peds hospice for one, plus it was a Saturday evening. What we did do, we called Bridges program at OHSU, and the pharmacist went in on a Saturday night, made the meds. We got the grandma to pick them up, transport them to the other grandma to transport them to the coast. So we were in Salem, got her through the weekend, and then it was like, okay, what are we gonna do? What do we do? Because they kept going back and forth out of our service area and not. And we ended up keeping her on and having a travel contract for when they were just outside of the service area, not at the coast, more in the Portland area. It was so complicated, and it was what was best for the baby, right?
Yeah.
And the family. They were a mess, and they needed all the support they could get. But
So
Does the
that's-
concurrent care play a part of that at all? You know, for our peds patients, because they can do concurrent care?
Sure, I mean, they can get concurrent care, but it didn't really mean anything.
Right,
if we
because they
keep-
wouldn't have gotten the special meds at the
Right.
coast.
Right,
Yeah.
yeah, somebody had to
Right.
get them what
That's
they
an
needed.
example of the gyrations that hospices go through to serve their
Right.
Yeah.
patients. My gosh, yeah.
Yeah, it was phenomenal and rewarding and incredibly difficult for everybody because it was just, it was a baby.
Yeah.
And young parents who were a mess.
Yeah.
I happen to have spied someone who just snuck in the back door, everybody. Say hello to Judy Lund Person. Judy, we hope you're going to be around at our reception. Hey, there's some free food coming up in a little while. So we're really at the end of this session. So, Rochelle, do you want to ask your question while Judy's here or wait for tomorrow? Because we did just mention your name, Judy. I said, that's a great question for Judy Lund Person. So, Judy, Rochelle, you might have to come to the microphone.
Oh, good thought, yeah. Okay, sorry to repeat for everybody else, but around discharging for extended prognosis, my understanding has always been that we have a day or a few days or maybe some unspecified period of time, maybe even a week or two, to make the plan to coordinate care for the patients next. And the latest thing I heard on a webinar was that the minute that chart has the word stable in it or not declining as expected, that billing Medicare needs to stop instantaneously, and then free care.
No, not true. Because what you really need to be doing is documenting that you are doing discharge planning. That's really the core of what you put in the chart is you are beginning to plan for the patient's discharge, you're doing discharge planning, you're looking for placement, whatever it is you're doing. But no, you're not going to no. You're developing a plan for the patient to safely be discharged from your care.
Thank you.
Thank you, Judy. That was just a teaser for tomorrow. So thank you all for your attention today. Thank you to our panelists. We appreciate your attention. Those of you who can hang around for the reception, that'll be in about 45 minutes. And we will see you tomorrow morning.